course, we have going to bring with our first session, which is surface guided radiation therapy by Dr. Ben. Welcome, sir. Okay.
I'm a bit taller. Thank you for being here early. So we will start with, I would think, kind of a lighter topic, surface-guided radiation therapy. Yeah, I don't know whether you all know what we're talking about here, but this is the use of optical imaging of the patient surface to control the patient setup. So what you see here, you see basically how it works. You see on this in this picture. So you project a light pattern on the patient's skin, and you image that with cameras mounted on the ceiling, and it gives you the coordinates of regions of interest on the patient's skin relative to the isocenter. So it's really meant to set up and check setup of patients. So the measured patient surface is there as compared to the reference surface. It gives you 6D errors, so also rotations. The reference can be two really. Sometimes it's the planning CT scan if you use it for patient setup. Sometimes it's also used the first optical image in a fraction, so that is then used for monitoring the setup during fraction. So whether or not there is intra-fraction motion of the patient. So this is one of the available systems. It basically shows how it works. You see that there is light shining on the patient's head in this case, and in the same boxes that you see on the ceiling, there are also cameras to look at the patient. So to look at the pattern that is on the patient. So if you see these pickles, you see that is the pattern that I'm talking about. Okay, so some examples of regions of interest. Normally you don't use the whole patient to image, but just some really regions of interest. But there is some. You need some I don't know how you say that. I mean some depth differences, and you see. So this is a good area. This is a breast, and you see here also. So there is at least three systems around. So the first is Align RT, that is produced by Vision RT. The Catalyst by CRAD, and then Varian has Identify. And I must say, yesterday evening I discovered there is at least a fourth system, and that is the X-Tract system by BrainLab. They also have a system now. But I will not discuss that here. Actually, I do not know a lot about that system. Okay, some characteristics. So you see the systems, you see them here, so the three systems. And if you look at the field of view, it's very big, as you can see for all of them. So they can really view big fields, although normally the region of interest is not that huge, but they have a big field of view. The frame rate is really nice, so you have, let's say, more than 10, well, this is, yeah, you can always have more than 10 frames per second. So it's really fast, so it's kind of continuous movement you can see. The accuracy is very high. Of course, these are numbers done with a phantom. So on the patient that may be a bit lower, but still, I mean, this is really nice accuracy. So the main applications. So basically, I already mentioned this. So the first one is guiding the daily patient setup at the LINAC prior to the start of dose delivery. And the other one is continuous interfraction monitoring of setup during delivery. So it's really quite good, certainly for monitoring of intrafraction motion. So for that one, for the first one, the reference is the patient outline in the planning CT, or at least a region of interest of that. For accuracy, you need a strong correlation, of course, between the skin region of interest and the target OER motion. So it's used a lot for breast and certainly for deep inspiration breath hold treatments. I'll come back to that. And for breast, of course, the target is visible. That is important. But one should also note that the heart is not visible. So if there is some rotation thing in there, or maybe the heart is not where you think it should be. And this is to note. I will just already anticipate here. So often this is still combined with cone beam CT. Normally you cannot replace cone beam CT by this system. I come back to that. So for deep-seated tumors, so you may have internal motion, and so you can set up the patient, but doesn't mean that you set up the tumor correctly. And then, so SGRT and cone beam CT are often combined in this initial patient setup. And the initial optical setup may be faster and more accurate than using tattoos. This is also the experience in our center. We'll also come back to that. So it's faster and more accurate. So I've heard one of our technicians say, now we used to have 3 points, and now we have thousands of points on the patient. So kind of makes sense, right? So for the second application, so intrafraction monitoring, so the reference can be the planning CT, but it's also often an optical image acquired just after the cone beam CT-based setup. It's often used for patient monitoring during deep inspiration breath hold, as I mentioned. There can be coupling with the LINAC, so the beam then switches off if the motion is outside some threshold level. I mentioned that already yesterday. Some people seem to use that as a virtual mask, so there's not anymore a mask, but they do intrafraction monitoring and then say it's kind of a mask, can replace a mask. Yeah, I think we have to if you want to do that, you have to really be careful and see whether that is indeed possible. I mean, this is of course really good in the sense that you cannot do this with X-rays, because you cannot just always X-ray the patient while you treat. Too much dose. This is a nice feature of these systems. So as you can see here, and also for example here, if there is a problem with the posture of the patient, you see it and you can correct, you can kind of adjust the patient and correct for that. So that is not necessarily directly part of the target, but I mean, we know that if the shoulder has an importance for the setup of the patient and of the tumor, and so if the shoulder is not okay with this system, with these systems, you can correct for that, which is, I think, a nice feature. So much reported clinical applications. For initial patient setup, so no tattoos, but this is mostly followed by cone beam CT. Deep inspiration, breath hold guidance, that is there. It's used a lot for that, and so breast cancer, lung cancer, lymphoma, and then intracranial initial setup without cone beam CT. There is a lot of papers on that, and the real-time patient monitoring. This is just to show that with deep inspiration breath hold of the left breast cancer, you can really protect the heart. And so here you see an exhale scan, and you see here the heart is quite close to the target, And if you look here with deep inspiration breath hold, there's a nice separation of the two. So it's really effective for treating left breast cancer. Can I have do a small poll? So who is treating left-sided breast cancer with deep inspiration breath hold? Okay, about 30–40%, I would think. And yeah, I think if you talk with your colleagues about that, they will confirm that this is really helpful. And I mean, it's difficult to measure the impact of this now because this is a long-term effect, but it cannot be different than that. In the longer term, we will see that a lot of cardiac incidents have disappeared, so you don't get them, maybe not anymore or much less frequently, because you can really protect the heart. Yeah, so this is, so hard dose can result in a major toxicity. I showed this graph also yesterday. So if the mean hard dose goes up, the gray, then major coronary events go up with 7.4%. So it's a big increase. Yeah, so now I will show a video of deep inspiration breath hold guidance with an aligned RT system. So we have that system in our place, and this is for the thorax patients. I hope it works. No sound. Can I do something with that? Should I do something? Ooh. No. Okay, maybe. Probably will work now. Thank you. Is it possible? I can hear it, but I cannot translate that fast. You cannot handle that? Okay, I will just, okay, let's go back. I will just talk about it. I've seen him. So this is the real-time coach, and this is a monitor. The patient is looking at this thing and at the top here, and can see whether the breath hold is okay. So this yellow bar should be in this white bar here, and then the patient is okay. So the breath hold is where it should be. Oh, okay. This is basically how, and this is helpful. And so our RTTs have tested this, so with and without, and they see a very small improvement. It's not huge, but they see an improvement of the accuracy of the setup. Okay. Oh. So intracranial treatment. So what is reported is the use of an open mask, more open as a normal head and neck mask, as you can see, or a brain mask. So I mean, people claim that they can avoid invasive head frame, bite blocks, etc. Again, if you want to try to do that, be very careful, and you have to really test that. This is reported, and yeah, maybe in your hands it works differently. Okay. Okay. Now I try again. No. It's okay. It's okay. Don't worry. It's okay. Thank you. You hear it, huh?
It's positioned so the patient can easily see the screen. This tool helps the patient better visually understand if they need to take a deeper or shallower breath. The patient has achieved the optimal breath hold amplitude when the moving bar is in the middle of the white threshold window. Once the patient's ready to treat, load up the LINAC and instruct the patient to take a breath in and hold. When all real-time deltas are within tolerance, treatment can commence. And the LINE-RT Advance will continue monitoring for intrafraction motion management throughout the treatment.
Okay. Thank you. Yeah, so for patient setup, yeah, there are quite some studies that demonstrate that this should be equivalent to X-ray based IGRT. Other studies see bigger differences. Depends also on the tumor site, of course. Yeah, where it's also, and I think this is a very nice application, is you can easily do continuous patient monitoring. Some examples of ROIs, so regions of interest, and you see that here they exclude the eyes probably because of some motion things that it's not stable enough, so they use not the eyes here. So I mean, it really needs some experience, and you have to know how to do it. So this is a rather interesting paper, and so this here describes what the paper is about. So can head and neck patients be treated without the mask? That's the question, the answer. It's not so clear in the title, but that's basically what they study. So they have an initial patient set up with SGRT, followed by cone beam CT for correction of errors, and then they use SGRT for monitoring and, if needed, correction of intrafraction motion during treatment. So basically, this is this virtual mask idea, and this is what they find. In conclusion, we have shown in this study for the first time in literature that maskless treatment of head and neck cancer patients, which is much more patient-friendly than applying a mask, is feasible. If SGRT is applied for accurate patient setup, as well as monitoring and correcting for intrafraction motion. But you have to understand, so the initial setup is again with cone beam CT. Another thing what they say is 16 out of 19 patients preferred treatment without the mask. While the 3 patients who preferred the mask only did so since they feared motion without a mask and felt they had to concentrate more in order to lie still. So there's also kind of a patient preference thing here. So some people got a little bit nervous of this. Okay, some experience is in our center. So Kirsten is one of the RTTs leading the introduction and use of this technology in our center. So we have that now on all Linux, all equipment, and so they were able to reach one of the national newspapers with this. Apparently, it was found big news that that patient did not longer need tattoos. So this is more in detail what we do. So we have aligned RTs on all Linux, identify at ethos, and there is no surface guidance at our CyberKnife units. There is no IGRT systems in treatment preparation, so we don't have them for the planning CT or training or whatever. So patients get a training of around half an hour, how to do it. So SGRT replaces tattoos now in almost all patients that do not have a mask, which is, I think, is about 70% of the total. So there is hardly any more tattoos around in this department. This is very recent, so this is in May of this year or something. So for final patient setup and corrections, SGRT is always followed by cone beam CT. So it's not that in our hands it has replaced cone beam CT. And I talked with Kirsten about this, and there is also not really plans to do so, to really avoid using cone beam CTs. Yeah, SGRT positioning is, they have a lot of data that they're going to publish. SGRT positioning is 16 seconds shorter than based on tattoos, and so 95% is smaller than, has less than 3 millimeters for setup, and 85% with tattoos. So it's faster. Yeah, and also what they noticed is there is slightly less cone beam CT rescanning. So sometimes, I think probably some of you have also noticed, while you do the scan, you find something, and you have to kind of reposition the patient and then do a rescan the patient, and that happens less if with this system, but it's really small differences. I mean, for them, I mean, they did have big patient numbers, so I mean, it was also significant, but yeah, it is, it's not too big. Yes, SGRT setup instead of tattoos resulted in less rotations in cervical cancer patients, especially with para-aortic nodes. So that was an advantage there. Yeah, so we use it a lot for deep infiltration breath hold guidance for left-sided breast, and also lymphoma since recently, I must say. So if you use this, I mentioned that already, this real-time coaching device, so that the patient sees this bar, then it becomes slightly more accurate. And due to the big numbers, it became really significant, but we're talking about here, so 0.1, 0.2 millimeters, something like that. It's not too much. So we use it also for VMAT gating. So normally we treat with tangential fields, but some patients we treat them with VMAT, and then it's with gating, and then this SGRC system automatically switches off the beam, so the patient can freely breathe. And freely breathe now. They are asked to do breath hold, but if it takes too long, they can let it go, and then the beam will switch off, and if the breath hold is okay again, it will switch on again. So so they also tested this open mask procedure in head and neck cancer, and what they found is there were too many rotations, and we don't have a 6D correction. And Drew yesterday told us that 6D corrections also has its limitations. So we don't do this anymore. So our head and neck cancer patients get a normal mask, and we don't use this SGRT for these patients. Here you see some regions of interest that they use. So this was also interesting. So these are breast cancer patients, but they also, the region of interest also includes this here. And I was told that this was better for internal anatomy, and so especially the heart. They think it's better. They can better position also the heart if they use also this as region of interest. And then lastly, so this is very much RTT driven. I see that they are really happy with this system. It's something that gives them control, and gives also the patient control. Certainly if they can see what they do, it seems that it has an added value. I must say, for years I was more critical on this, but I think it can have an added value. So claimed advantages of surface-guided radiotherapy. So it's non-radiographic, so you can limit imaging dose. You can do continuous patient monitoring during treatment. You have a large field of view. yeah, you image the full surface instead of a few external markers. This is this thing of 3 versus thousands of markers, kind of. Adjust patient position and posture. That is also a nice feature, I think, and also useful. Multiple systems on the ceiling, so the patient is always visible. Also in non-coplanar treatments, the same. Potential for avoiding invasive frames, bite blocks and masks. That's what they claim, right? Potential for avoiding tattoos. And it may also be, it is a little bit more accurate even. You can avoid anesthesia and or larger margins for children. These are claims. So again, you have to test it in your center. So challenges of SGRT is there have been found large deviations between SGRT and cone beam CT setup. So as always, you need to be careful and study well what's going on. So SGRT is not generally considered the gold standard of daily patient setup. So the gold standard is cone beam CT, and maybe in some situations you can replace it, but you have to check that. So SGRT is often combined with X-ray based SGRT. Yeah, if you don't do this X-ray based imaging, you have a potential of tumor miss, and you could also increase toxicity. So, yeah, so you have to be careful. Yeah, you need to have some depth differences in the skin where you are. If it's very flat, the system doesn't work. There is some issues with patients with a darker skin is reported. Yeah, and you need to do extensive extensive acceptance testing and also commissioning and QA with these systems. So I mean, if you really rely on these systems, so they have to be really accurate and precise. Thank you very much. I don't know whether somebody has a question or a comment.
Sir, I want to ask one question. In proton therapy center, due to the bulky gantry size, what is the limitation in use?
For the proton center?
Proton center due to the bulky gantry size.
I'm not aware. I mean, we don't have them in the proton center yet. So I don't see why it wouldn't work in a proton center. So there is a gantry. It's maybe a bit bigger, but
the limitation of the cameras.
Yeah, maybe you have to really figure out how to put the cameras on the ceiling. But so normally there are 3 of these systems, and yeah, I mean, so I don't have experience, but I'm not pessimistic, let's put it that way, but maybe it needs some thinking of where to put them, really, how to put them.
Thank you.
Thank you.
Good morning, sir.
Good morning.
My question is, in case of head and neck cancer, if the patient shows some more weight reduction, how it will be applicable then?
Sorry, are you talking about cervical cancer?
Head and neck cancer.
Hand and neck.
Yes, sir.
And then?
Then weight reduction of more than 5%, then how it will be applicable in head and neck cancer?
I don't understand this question. What is the...
Patient is losing the weight, then how it will be applicable, how SGRT will be applicable there?
Sorry.
In head and neck cancer, initially when you're using the SGRT, but after some fraction reduce the weight loss. So what is the strategy of SGRT?
Okay, yeah, with the weight loss, yeah. Yeah, so if there is weight loss, you have a problem if you only have this. But I mean, we always combine it with cone beam CT. So And so you see a little bit more, and if there is weight loss, there's rescanning and replanning.
Okay, thank you, sir.
We recently installed this system, but initial experience, one or two patients whom we wanted to treat for left-sided breast cancer, and they were given training to breath hold. Somehow they were not very comfortable with the light coming green and red and green and red,
Oh, yeah?
and they were quite confused compared to the ABC which we were using as a device.
Yeah.
So what is your experience of ABC versus SGRT in, for active breath control?
Yeah, yeah. So before we had nothing. So we did breath hold. It was really voluntarily, and yeah, there was also a time there was something on the patient's chest, and from outside the RTTs instructed the patient to take a breath and stop, and then they treated. So there was nothing else, and so now we are doing it in this way, and I must say I have not heard about this issue with colors and lights, but yeah, it looks a bit strange, and I have not experienced it myself, but they have not told me that this is an issue for them. I don't know. I don't think so.
Whether SGRT triggered more adaptive planning, the use of SGRT,
Yeah.
Whether it triggered more adaptive planning?
For adaptive planning.
Yes, whether means the center without SGRT and with SGRT, whether there is more number of adaptive plannings or...
I think not in our case, because I mean, if you combine it with, I mean, driving for us is still the cone beam CT, and if we do adaptive replanning, it is based on cone beam CT, and so doesn't change. I don't know if you only use this, which I say be careful if you do that. But you see, I mean, it's also with this system, if there is weight loss, you see it. And so you would also replan, I think. Yeah.
So I want to ask regarding the diabetes treatment. So initially we acquire the patient, suppose in the 1 centimeter amplitude the diabetes in CT scan. But we observe that at the time of the implementation in the treatment delivery, so patient lung capacity increase. So that's time in HGRT what to role play, because increase the lung the height. So due to the increase the breathing like 1-2, initially threshold is 1 centimeter, but after that we found 1.3 centimeter. So are you changing the planning or adjust the threshold?
So do you say that, because I'm thinking what is happening, so do you say that during treatment that the kind of the lung volume changes? Is that what you're kind of saying?
Uncertainty of the breathing pattern.
Again?
Uncertainty of the breathing pattern.
Yeah. Uncertainty.
Yes, sir.
Yeah, but what I don't understand in that, first of all, I mean, so we make a cone beam scan in breath hold, right? So we let them go every day. Let them go to this to this white bar,
Right.
and then make a cone beam CT scan, right?
Right.
And we check the anatomy, and if the anatomy is okay, so there is no problem. Is that right?
No, but when delivering the treatment, so we observe that sometimes patient taking some higher level, then sometimes taking the lower level. So that time IGRT, what role play? So stop the treatment.
During a fraction, you mean?
During the yes.
So you think that although the patient visually would be okay,
Yes.
she is not okay?
say, suppose in the preparation, in the initial planning CT,
Yeah.
the deep inspiration is at 1 centimeter amplitude, but he notices that the patient gets more comfortable, and then during the treatment, when the patient is taking a deep breath, it's going beyond 1 centimeter, and potentially that means that if you there's potential for more cardiac sparing, because the amplitude now, the comfortable amplitude is now bigger, and therefore have you faced a situation where in such a scenario you would replan the patient?
They have not talked about that with me, so I wouldn't know. I'm sure that it's not happening a lot, otherwise they would have told me. So I cannot really, maybe there is some patients that have this feature with that, but it's certainly not that we have seen that a lot, no. And I also wouldn't know what to do, I mean, because I also don't know how you note that, because when you always ask them, no. I wouldn't know what they would do. Sorry, yeah. So it's an interesting question. Yeah.
Anybody else? Yes.
Good morning, sir.
Good morning.
What are the coaching methods you are using for the DABH?
What are?
The coaching methods. What kind of coaching or training? Yeah.
Okay. Oh yeah. So this is half an hour. What they do. This is a few days before treatment. So they, but there is not this system where they see the bar, and so it's just. I mean, they measure. They are coached that they have to keep the breath hold. They measure how long they can keep the breath hold. These kind of things, and they have to repeat. And also, I'm told that they are also, the patient are also instructed to practice at home, and to continue practicing at home. So it's not very technical, this whole coaching preparation thing. It's more, it's really a coaching. So I mean, and there is a measurement of how long they can do it, and and I was told that the majority of the patients can hold it for 40 seconds.
I think this evening this afternoon you'll have a breast cancer clinical session where I think that Dr. Shantam and a few others will tell you what their techniques are, and I think that coaching is an important component, so you can verify the practices with others.
Thank you.
Sir, what is the tolerance limit of intrafacial motion in terms of translation and rotational movement, which triggers to beam off during SGRT?
What are the thresholds, like in the SGRT, in your SGRT practice? Do you, for gating or for stopping the beam, do you have a specific threshold?
Yeah, 3 millimeters.
3 millimeters.
And rotational direction?
In all directions.
Okay.
Yeah, so if in one direction it's more than 3 millimeters, stops.
Okay, thank you, sir.
Sir, I have two questions, and I think these are very simple. How well SGRT works in deep-seated tumor, just like in lungs tumor?
In lung tumors?
Yeah.
Yeah. I think we don't use it for lung tumors. I don't know whether lung cancer patients can hold their breath that long. I think it is used. I think in the UK I've seen that it has been used or is being used. And but I mean, you don't see the lung tumor, right? So this can only work together with cone beam CT. And then a second condition is that that the patients can hold their breath. I mean, they can really do it in a reproducible way.
Okay, thank you. And next question is related to your last slide. You showed that there is large deviation between SGRT and CBCT setup. So
Yeah.
what are the reason there?
Ah.
Or how we can say that which one is the better? CBCT is better or SGRT better, or
The
on which we depend?
cone beam CT is the standard, so it's always better. And if there is a deviation, there's a problem. Well, normally, I mean, if you do the cone beam CT well, that is considered the gold standard. So if the SGRT gives something else, then there's a problem with the SGRT. And I cannot remember, some time ago that I read these papers, whether they really found what were the reasons. But clearly, I mean, if this happens, I would always follow, in normal cases, the cone beam CT, because that is the gold standard.
Okay, thank you.
You're welcome.
Ben, you've described 3 systems for SGRT, one of which is a variant system, but out of the others, CRAD and Align-RT, are these compatible with both the other vendors, that is Varian and Electa? And the other question is there any difference in the technique of the technology for ring gantry systems versus C-arm gantry systems using SGRT?
Yeah. So is it? Are they kind of compatible? Yeah. So we have both of them. I have not heard of. I mean, there are differences. There are subtle differences in the software also. So I remember that you told me that. I mean, for one system had some nice feature that the other system didn't have, but I mean. They work with both, so we have Identify and this Vision RT, right? And they work with both, and and in the whole department, they have now decided to go for the 2 lists. So apparently they can work with both systems without limitation. But in a ring gantry, there's indeed a difference because I mean, there you have a problem of visibility, right? And so in the ethos systems, there is also a camera coming from the back. So they have this ring. So there are cameras and light coming from here, and there's also something in the back to do with it. And is that answering your question?
Yeah. Thanks.
Okay. Thank you.
Thank you, Ben.
Thank you, sir. Now our next session is Adaptive Radiation Therapy Principles by Dr. Malik. We welcome you, sir.
Before we go on to the talk, I'd like you to answer a few questions on Mentimeter, because we have a long session on adaptive radiotherapy, and we would like to know how many of you use it, and what's your experience, or what kind of technologies you use. So I'd like you to log on to this poll. And these are very simple questions. They're not checking your knowledge. They're basically asking you for your practice patterns. Right? Are we good to move? Right. So first, a very simple question. Do you use adaptive radiotherapy? So it seems that about 85% of you
have used adaptive radiotherapy in your clinical practice. So this is a relevant, very relevant topic that we are discussing today. Next, in which clinical sites I may have, I'm sorry, I think I got the question a little wrong. So just tell me your most common clinical site. I may not have allowed multiple answers here. Yeah. Yeah, so it seems that, you know, head and neck cancers seem to be, you know, the predominantly common site where adaptive radiotherapy is used in your practice. In terms of infrastructure, I think it's quite interesting. There are a number of people who use both MR and CT based adaptation. And is it because you do you have an MR LINAC, or do you mean that it's you're using MRI images to take a decision on treatment? Right. Have any of you done online adaptive radiotherapy? And by online, we mean that the patient is on the couch, you've taken an image, now while the patient is on the couch, you're changing the treatment and giving the patient a new treatment. And of course that we know that this is going to be less common because it's more technology dependent, and I'm sure that in the coming talks you're going to see how you know, the experts do it. Thank you. So let's go on to the introductory talk. This is an introduction. We are going to see the details in you know, the upcoming presentations, and we have CT based adaptive and MR adaptive, and then Dr. Anand is going to talk about the evidence. So what is adaptive radiotherapy? There are, you know, many definitions. The original definition by Jan, and this is many years ago, so adaptive radiotherapy is not a tremendously new technique, is that it's a closed loop radiation treatment process where the treatment plan can be modified using a systematic feedback of measurements. In plain and simple English, it means that, you know, based on what you're seeing, a certain change, a certain magnitude of change, you are making a decision to change the treatment plan, right? And, you know, but you might ask that, you know, I'm already giving a margin, and in real life, we know that, you know, the anatomy doesn't remain exactly the same. But we know that, we've known that for years. And we also know that, you know, sometimes when we give our PTV margins or we use ITV, etc., we are, you know, trying to accommodate for anatomical changes that are happening in the body, right? So in some common sites, things like an ITV based planning would take into account anatomical changes. And there are other technologies like, you know, confidence limited PTVs, etc., which you know, do multiple scans and try to generate a margin on the basis of that, based on the first few treatments. But we also know that this is not always possible. It's not always possible to model or predict what is going to happen in a patient. Now, in head and neck cancer, which is one of the commonest sites we treat, we know that, you know, there are patients who have remarkable responses. No big nodal mass which regresses, a big nasopharyngeal or paranasal sinus mass, or a base of skull mass which is becoming smaller as the treatment goes on. You know, we also know about weight loss, which can, you know, and shrinkage of the parotids as the treatment progresses. So these are not something which you can accommodate with margins. And in lung cancer, you can have, you know, an atelectasis which opens up because a blocked airway opens up because of treatment response, and the entire anatomy shifts. So this is also not something that you can model with margins. And in cervical cancer, you also have remarkable responses sometimes while the treatment is going on. And this is again going to bring the organs at risk within the high dose PTV, and you cannot, you'll have to make a decision regarding whether you want to change the treatment. Now, if I wanted to, summarize the indications of the clinical scenarios where adaptive planning might be required, there can be, you can divide them into the temporal relationship or the time when this happens. Probably the most common use is for gradual, on the right, for gradual interfraction changes. So there are things like tumor regression, there are things like weight loss, which prompts us to stop the treatment and adapt the treatment and restart the treatment. You can also need to do adaptive treatment for random interfraction changes, sometimes for rectal bladder filling, bowel loop positions, tumor bed variations in breast cancer, atelectasis opening up suddenly in a lung cancer patient. Now, this is not a gradual change. This is a sudden, day-to-day change. And rarely you would want to do some kind of adaptation on a real-time basis for things that are happening while the treatment is going on. When we generally think of adaptive radiotherapy, we are usually thinking of the gradual interfraction changes, but more and more with improvement in technologies, we are moving towards, changes that are happening suddenly during treatment and changes that are happening while the treatment is going on. So if you talk about triggers of adaptive radiotherapy, again, as I mentioned, this is a table which lists out the possible indications for which adaptation might be required. Now, you will notice that, right at the end, I've written about tumor biological change. Now, this is, of course, an experimental thing. And, we would sometimes want to do adapting doses based on response on a PET CT or based on, some other functional imaging. So in the future, we might see emergence of these uses based on, changes, reports of clinical trials. But before we go on to, thinking that any type of tumor shrinkage or change in a tumor shape should prompt a change in treatment plan, you have to ask that, do we know whether, for example, reducing your high-dose CTV or high-dose, region is a safe thing? And to be honest, we don't have very high-quality data on this. Potentially, it is possible that, you will, by shrinking the tumor volume, by shrinking the CTVs, you're going to reduce those to the normal structures, but there could be some uncertainties. It's important to keep that in mind. And there could be microscopic disease that is left behind in the area where you cannot see gross disease anymore. And this needs to be tested properly in well-designed clinical trials. I mentioned biological adaptation, and it is possible, and we are going to see the results of some trials in the near future, which are using a response-based method to adapt treatment while the treatment is going on. So this is, a trial that is trying to reduce the volume and increase the dose in lung cancer patients while they are on treatment. So if you are going to do adaptive radiotherapy, what are the methods that are used? Now, the simplest method is what is known as offline adaptive, which means that at some point in the treatment, either in a pre-planned way or based on a certain trigger, you decide that the treatment plan will be changed. You're not going to be able to do anything on that particular day. So you take a rescan of the patient, you replan the patient, and the new plan gets started downstream. It can happen the next day, it can happen after a few days, but you're not using the image for making a change before that day's treatment is going to take place, and therefore this is called offline adaptive radiotherapy. And in some institutions, you have a very systematic process, a traffic light protocol for triggering ART. This is just one example. I'm sure there are many different examples, and this is one example from a publication on head and neck cancer where a traffic light system has been used, which either prompts no action or no immediate action, or immediate action based on the magnitude of the change. So this is a systematic way of looking at when and how to do adaptive radiotherapy. But what is coming up increasingly with better technology is online adaptive. Now what online adaptive means is that the replan is executed while the patient is on couch, which means that after your scan and you've checked the scan, there is instituted a cycle where there is a deformable image registration, some kind of either a manual or auto segmentation, a prediction of dose and a check whether there is a dose difference. If there is a dose difference, then a plan re-optimization, some sort of a re-QA, and then you treat with a new plan, right? And it is potentially possible with new technology to do that for every fraction. So we are going to probably see, the technology behind it and the process behind it in the talks that are forthcoming. One of the key elements of doing online registration and sometimes also offline registration is deformable image registration, which means that you're going to use a scan that is from the board, from the scanner, and you're going to do a deformable image registration either for propagating the contours, and the deformable image registration process uses mathematical formulations that creates a deformation vector fields that bring the anatomy correctly into position and sees what are the changes, what are the magnitude of changes, helps you propagate the contours again and checks the dose. Now, as you can imagine, these processes will require quality checks because many things are getting automated, many things are not perfect in that cycle. And this is a publication that shows the recommendations from NRG Oncology clinical trials groups that tell you that if you want to do an online adaptive protocol, there are several steps, the imaging, the registration, the contouring, and end-to-end workflow that needs to be checked. But you also have real-time adaptive treatment, which means that there are some technologies where the MLCs can automatically change based on changes due to respiratory motion or peristalsis, and there are methodologies for that. I don't think we are going to discuss that in great detail today, but this is also a technology that is available. There are two broad categories of adaptation technologies. One is CT or PET-CT based and MR based, and we are going to have lengthy discussions on that in the upcoming talks. But I want to, before I end, I want to emphasize that what is the goal, the real goal of adaptive technology? Is it just to get more similar dose distributions as the planning CT? Is it to look at some marker of better side effects like salivary flow or functional imaging or radiological response? Or is it actually to improve clinical outcomes or outcomes that matter for patients? I'll give you an example of adaptive radiotherapy for parotid sparing. Right? So Dr. Hope mentioned the ARTIX trial yesterday. This was a trial that randomized patients to standard IMRT with IGRT versus weekly adaptive replanning. And the primary objective was to look at salivary flow rates at 12 months. And this is a unique randomized trial because it's very rare to find randomized trials looking at technologies like this. And it found that in terms of actual salivary flow rates, and in terms of patient-reported outcomes, weekly replanning did not show a benefit, right? So what matters to patients is that am I getting less xerostomia from adaptive replanning, right? And this trial showed that weekly replanning did not help in those outcomes. Even though they found that the salivary scintigraphy, if you do a scan, the scintigraphy scan, there was an improvement, but it did not translate into better salivary flow rates or better, patient-reported outcomes. Despite the fact that this adaptive planning process resulted in, about a 10,000 or an 8,000 euro increase in cost. And the cost effectiveness ratio, or the benefit for, to get one patient with less xerostomia, was calculated at between 162,000 euro to 194,000 euro at 2 years. Now, in our hospital, we've done a few adaptive radiotherapy studies. The first was a prospective study to look at the resource utilization, how much more time is required to do adaptive radiotherapy and the downstream effects. And we found that you basically doubled your effort. But we also found that patients who needed adaptive radiotherapy, and we did adaptive radiotherapy on those who had a parotid dose increase of 2% or more, there was, the xerostomia scores came back close to the baseline at about 9 months. And we are now running a randomized control trial where, unlike the Arctics trial, which did adaptive radiotherapy for everyone, we are doing adaptive radiotherapy for patients whose parotid doses were between 25 to 30 gray and getting bilateral parotid dose, to select patients who are more sensitive probably to changes of doses. There is a dose check at 3 weeks, and if there is a more than 2% increase, they're getting randomized to either no adaptation or adaptation, and we are going to see patient-reported outcomes using a linear mixed model comparison. Now, a different type of adaptation is adaptation for dose escalation using response with a PET-CT scan, and this other randomized control trial in lung cancer showed that this was a phase 2 study, showed that there is some promise in terms of reducing, improving the 15-month local control rate and reducing the acute toxicities. So based on the results of this study, they're going to do a phase 3 randomized control trial. So in terms of clinical scenarios where adaptive radiotherapy should focus upon, it's important to emphasize that the highest priority of adaptation is towards improving disease control by preventing target miss or dose escalating based on response, followed by reducing risk of injury to critical normal tissues, then followed by reducing toxicity to other normal tissues. So our priorities in terms of how we should use adaptation should be very clear. So to summarize, modern technologies are now available for sophisticated end-to-end workflows using multimodality imaging, automated contour adjustments, plan re-optimizations. The dosimetric benefit is very, very clear. But we have to emphasize that we need to identify the clinical benefit to patients which need to be tested in well-designed clinical trials with the correct endpoints. Thank you. So I think maybe we can take questions after the end of the entire session, I think, so that we don't get late. Yeah.
Thank you, sir. Next, we have a session on CT-based adaptive radiation therapy technology by Dr. Sai Subramaniam. Over to you, sir.
Good morning. Yeah. I'll start away. I think he has very nicely thought about the adaptive, so I'll just straight away go with the technology. Of course, we are in the era of genomics, immunotherapy, biological imaging, and then artificial intelligence. All those things are there, so there is definitely adaptive therapy treatments will redefine the RT era and then gets added to it. And just to give you some glimpse on that, like a nice paper which is justifying the adaptive was the pancreatic 2-year survival with the adaptive radiotherapy in MR-based treatments has shown that some benefits. So definitely there is some role, not fully, but okay. If you look at the adaptation, of course, if you do if there is a weight loss or a tumor regression or some organ functions, then it can be done with the offline. But when you see some changes with target change or a rectal filling or reventilation of lung, of course, you can do day by day. And bladder filling, of course, we can show something on the MR Linac in the next talk, where it has to be done in minutes. And then if we want to do some kind of cardiac stereotherapy treatments, then in that case, it has to be done in real time. So it's a real-time adaptive treatments. Coming to CT-based adaptive treatments, of course, we are all doing it, and I could see that in the poll, there are a good number of people are doing that. Generally, we just do a simple CT, and then do plan, and then QA, and then treat the patient. If there is some changes, then you go for again a repeat CT, and then plan it. In case of online, the whole process is done in a single day. So you have to do the contouring, planning, treatment, everything in the day with the patient on couch. So when to perform, of course, offline, between fractions, online, immediately during the delivery, and dynamic, which means like immediate during the intra-fraction, so that's during the delivery. If you look at the major things which I want to focus here is that like the technology used here for the offline, you have already the technology available, but for the online, you have to have a fast treatment planning system, phantomless QA, big problem, and then proper imaging softwares for the deformation and other things, and the electron density mapping, big issues. So these are the big problem with the online, and if you go into real time, there are too many things. Like, you have to, there is nothing where you can do a contouring there, so you have to have some kind of a mechanism to react to it and understand what's going to happen, and accordingly the system react to it. So it's basically an in vivo way of, or log-based files, you have to do that. Going forward with CT-based adaptive therapy, as I said, with the patient on couch, you have to do an adaptive treatment. So in that case, you need to have a very high quality daily imaging, rapid recontouring, rapid planning, plan review, and quality assurance without phantom. So that's again a problem. And then not only that, you have to have some kind of for the entire workflow, efficiency has to be there so that you can do everyday adaptation at the clinic. Major factors which can affect is that like the Horn speed unit, if your CT value is more than 10%, or more than 20%, there will be a dose variation of 1.4%. So that's quite challenging, because most of the time you have the CBCT available in our clinic for adaptation. So to get this is again a big problem. And then geometric integrity should be less than 1 mm for a field size of 10 centimeter radial distance from isocenter, and for 2 mm for more than that. In any inaccuracy will lead to dose calculation error. And again, the field of view is again a big issue, because the detector sizes are very small. So in that case, you will not be able to cover the entire one, and it can lead to, again, may lead to erroneous deformal image registration. Artifacts can really amplify the problems, and then can create and can obscure the relevant anatomy delineation. And deformal registration has a lot of issues, but there slowly things are coming up, and then there are some models which are little better, but not very accurate. If you look at the available systems, it started with CT on rails with Siemens, good idea, that time, long time back. And of course, now it's not available, but other systems which are available is Varian Ethos and Electa Evo and Acuro Radisact. Of course, PET CT with Reflexion is there, but still they are in a very, very infancy state. But these things are quite available on the clinic with the FDA approved. But before getting into the technology, I want to just make sure that what are the things you should know when you have to have an adaptive treatment, and basically you go to do on CBCT-based adaptive treatments. So the main problem is the treatment isocenter. If you look at these previous technologies, the EVO, the Ethos, and Acuro Exactac, they all use CBCT, whereas the Siemens uses a CT scan. The only problem with the CT scan is that like the isocenter is different from the LINAC isocenter. That's the only area where they had an issue. Otherwise, all the things which needed for the adaptation is available with them. Maybe that's the reason why they stopped there, I don't know. But all the other guys, the isocenter accuracy is so good, because the treatment isocenter is the imaging isocenter, so no issues at all. But they have other issues, like the scaling and distance accuracy, low contrast resolution is always a big issue with CBCT, and the spatial resolution, uniformity, noise, and responsibility. We'll just see little on that. But before getting into that, we should know about what's the difference between a diagnostic CT and a cone beam CT. The major difference is that like in a fan beam CT, the diagnostic CT, we have the beam width opening is very small. It's only a 0.5 mm. width, we open up, and then the entire lateral, you open it and then do a CT scan. So that the thing is that like there is no scatter from the other areas to this primary area which you are scanning. So this makes it easy, and they have a curvilinear solid state detectors, and you can do very fast scan. This whole acquisition is only 5 to 15 seconds for the entire area of interest. But if you look at the cone beam, it's a flat panel detectors. The gantry rotation is very slow, and there are a lot of scatter contribution. As you could see here, when you scan this particular slice, the scatter from this slice is going to spoil that image. So definitely you have to account for that. And the speed of the rotation is quite slow, so motion is going to be an issue. So basically this major difference, geometry, plays a big role in this. And if you look at the scan, especially the scatter, you can see that quite a lot of scatter in the image. So this will not be useful for adaptive treatments. And if you slightly go into further, if you look at the CBCT, it's designed not for adaptive treatment. It's basically designed for image-guided treatment. So we cannot blame that. But if you look at the limitations, the field of view is small, artifacts are very high. HU accuracy is not there. As I said, if you have more than 20% HU value, you're going to have a 1.5% dose error. So definitely that's again an issue, and the image quality. But how do you overcome that? Okay, there are some nice techniques tried. The first is that like we know that from the diagnostic to the cone beam, the major issue is the scatter. So some kind of a technique we can follow and do it. One thing they tried was like by blocking the basically a source blocking technique, by inserting a tray with the lead blocks where you block one particular area and then do a scan, and then remove that one and then do a scan, so that particular walk cell, how much is the scatter contribution from when you block and without block, you get the value. So with that value, you can reconstruct it. Nice idea, but could not get much better quality of the image. So because they were not able to get the real scatter component, because when you do for individual things, the other scatter also comes to the picture. So then they went to the next level where they try to use the prior knowledge. Like, you have a CT scan for the same patient available with you. So you just create one shady map of that CT scan and then try to use that and do a reconstruction. Work well, but the only thing is it does not come to the level of diagnostic CT because the scatter component is still up there. Then we had some empirical approaches where we try to reconstruct it with the empirical formulas, but that also didn't clearly get the real scatter values. So the only way forward is to do a Monte Carlo simulation, and then with that they could really match and remove the component of the scatter. But the only problem is that it's a time consuming and it's not going to work on a clinic, and especially for adaptive treatments. So we had to find a way to do that. The one way of doing is that, like, the one which for a dose calculation, we have an accurate dose calculation for treatment of radiotherapy, where what we do is that, like, we just solve the linear Boltzmann equation and try to calculate each individual electron. You propagate that electron into the medium and then calculate the dose. Similarly, if you could solve the linear Boltzmann's equation and try to get the scatter component, then it could be really nice, because you could really get the real value. So this is a nice comparison where you have the Gen 4 Monte Carlo simulation, and then you have the linear Boltzmann equation solved to find out the scatter component. And then if you do a reconstruction with this, you could really get a image which is as good as you get with the diagnostic, which I will not say the equal, but something better than what is available. So basically they use a two-pass reconstruction technique, and then even the couch is modeled, because the couch also scatters the patients on the couch. So that also has been modeled to get the best quality. This is again a nice comparison. It's a basic scatter comparison, and you have the empirical formulae, and then you have the scatter correction by the convolution technique, and then you have the Accuros, where you could really see the dramatic improvement in the image quality. Again, the similar one with different filters. So the quality has definitely become better as compared with the other techniques. But not only the scatter, there is something else also there, because the acquisition time, because the CT acquisition time is quite fast, but when you see the acquisition in a normal conventional accelerator, it's quite slow. So this is also going to become a big issue, because the motion of the patient is going to create a problem in your acquisition. So you have to be really fast in doing that. So if you look at it, we are doing a lot of breath hold treatments. Even many times we do breath hold CBCTs, because before we treat any breast patient, you do a breath hold. How many times you do a breath hold treatment? The same number of times you do a breath hold to do a CBCT to make sure that is the tumor or the breast is the right place and the heart is at the right place before treatment. So similarly, if you do a breath hold CBCT, definitely the image quality is better. And as you could see, this is a breath hold fan beam CT, breath hold CBCT, free breathing CT, and breath hold CBCT, which is definitely better in this situation. But how much we can increase the speed, because in a conventional gantry it just goes with one rotation per minute, but when you look at the speed required for a diagnostic is quite a lot. You see, this is the speed with which you are going to take a CBCT, this side, left side, and this is the speed with which the conventional is doing it. So never we are going to match the conventional CT in that aspect, because it's 250 RPM, whereas here we go with 1 RPM, or nowadays with a conventional accelerator we are just pushing it with Hyperside 2 RPMs, but Halcyon can do 4, maybe Yamalinac does 6 or something, but we are nowhere in the comparison between 250 and 6, so we are not going to get that kind of a quality of image in that aspect. So these are the problems when you do a CBCT based adaptive treatments, but there are some solutions. Coming to the vendors, we have the Ethos, which is the first one which came with the CBCT. They have a faster revolution because they come with a ring gantry. That's one of the reasons where the ring gantry has been redesigned. They didn't go for a conventional CM accelerators because you cannot rotate the gantry with such a high speed. So you have to have something like this to do that. So that's the reason they came up with the 4 revolutions per minute in their mission. And of course, yesterday Dr. Ben has shown nicely about the MLCs and all. I don't want to go into that. They have a stacked MLC with 4 mm leaf width indirectly with the 2 stackings. But looking at the system from the adaptive point of view, it's a little redefined. Like, noise, the previous talk, Dr. Indranil has shown very nicely that why it's not getting translated. The main reason which we feel is that like these systems are designed for radiotherapy, then remodified for adaptive. The moment you remodify the system, this is what happens. The problem is that like even yesterday Dr. Indranil was telling about like I will want to get the best plan from my physicist. In that case, I'll push him to do that. But here, if you see the system in Ethos, the planning is very, it doesn't allow you to do the plan in a way you would like to have, or your clinician would like to see that, because your hands are restricted, because the ultimate aim of the system is to treat the patient as fast as possible. But in doing that, you are going to lose the one which you already created, like, the best plan. You cannot do a best plan because you are here, the whole concept of planning is different, because you create a influence organs at risk, you create a target which is physician intent, and then these are the structures which are going to play in your online adaptive treatment. So you create something like this and you create a plan. So, and not only that, these are the things only are going to come with that. So you are not having a real freedom to do a very good plan. So that makes a little difficult, and that could be one of the reasons where we could not get the best out of this technology. So going little into the system, like, as I said, this system contouring and planning is, contouring is similar to the conventional Eclipse, but only thing is that like you have a target and you have some other structures that in and around the target, 2 centimeters around the target has been defined as a influence structures, and that was given importance during the planning. And also the planning, they call it as intelligent optimization engine, because it does on its own some of the parameters which we have no control on that. So in that process, what happens is that it automatically creates a 9-field and a VMAT plan. For a non-lateralized field, fix a 9 or 7 or 12 field, and 2-arc or a 3-arc VMAT plan, or a lateralized target, you have 7-field or 2-arc plan. So this is like your hands are tied, because we are in the era of 4-pi rapid arc. So you are again going back to the simple technique where you cannot give the option to the user to do, or the clinician to have a best plan for this particular patient. And coming to the influence structures, as I said, they have the AI generated structures, and the AI controls these structures in and around the target, and they use that to do the planning. So what really happens in this system is that, like, the system try to create a plan based on the whatever the initial plan is done, and if you want to change it, the options are quite less. That's quite tight, because already you have the clinician is able to see some difference, and if you're not able to change it according to what you really would like to, then you are stuck, right? So they give an option like you do an adapt plan, or you treat the original plan with accepting the translational error, which normally we do that and treat the patient. So that's again a little issue on that. Maybe if they can open up the doors for that, then maybe it will be very useful to do that. And coming to the QA, of course, they have a Mobius online QA, 3-dimensional dose calculation with conversion collapse cone algorithm. So that should be quite good, and maybe very well used for dose calculation purpose and how it matches and all. And they have a nice offline workflow where they can do a dose accumulation of this one. But still, I would say that this is not like a cascaded radiotherapy where you want to do a treatment based on the previous day's treatment. That's not there, but still at least they are in that direction little on that. This is again a comparison between planning CT, CBCT, standard CT with the Halcyon, and then you have the iterative CBCT with Halcyon at the high speed. So you could really see the reduction in the artifacts more, and especially in other areas where you could see that. And I just added this picture just to show you that this is a ring gantry system, and then this is the SCIAM system. So more or less better in the ring gantry as compared with the C-arm gantry system images. And now they have come up with the HyperSight in the same ethos. The advantage is that, like, you have a big panel, 86 centimeters by 43 centimeters. So because your field of view is so high, so you're able to really image much larger area, new collimator, and large capacity X-ray tubes, because previously the X-ray tubes were we cannot do a two patients continuously of pelvic. Now we can do much better, and the speed is more, 6 revolutions per minute, and a 6-second CBCT. That's quite really interesting, because any patient can do a 10-second breath hold. So definitely with 6-second CBCT, you will be able to get a better image quality without much of motion artifacts. And they have a separate algorithm for metal artifact reduction, the MARS. And the main thing which I want to show you that the detector difference is that, like, the detector has a cesium iodide instead of the scintillating. Usual scintillating type is a gallium oxysulfide, but this cesium iodide is a thick material. So the advantage is that, like, the more the photons it can absorb, the better the quality of the image you get with that. And also they have the anti-grid on the detector side. That's a good one, because that can really reduce your scatter component to the primary component, so that which can really get you the best the primary component kernels, and also avoid the scatter component kernel getting into the image reconstruction. This is again, because of all these things, the HyperSight can get your HU values as close to a diagnostic CT. This is basically a profile of a CT scan comparing HU value of CT and the CBCT, and you could see a very good match on that. So this can really help you to give the confidence to the clinician that the dose you calculate on a CBCT is almost close to what you can do if the same patient, if you do a CT scan on that one. But having said all good about it, there are some issues. Of course, the deformal registration is as an issue. They use a B-spline algorithm from the velocity, good voxel-based point-to-point match. But only thing is that, like, because it uses a voxel, sometimes you can see that there is no bubble there, but there could be, it can really create a bubble there. So, air gap there, but there it can really create the air gap. So these are the things which are there. But even still, to be honest, we have variant auto contouring, but we are still struggling with that, because it is not giving the clinicians are not happy with the way it does. It is not up to the level of their expectation. Again, of course, they say that AI assisted, but sometimes this AI does crazy works. Like, to be given a nice example, when you do an auto contouring with the AI-based system with Siemens, a prostate was drawn as a cervix was drawn as a prostate, like, because it does not know what it's a male pelvic or a female pelvic, so that's sometimes scary. And you got a nice example here, it just missed the contouring this part. Although you say AI, a clinician has to check it because it can really do something totally wrong in the one. And also, coming to the MU variability on the plan, there are quite a lot. Even we see in the MR-Linac, a lot of variation between the plan MU and the delivery MU. Of course, in the MR-Linac, the reasons we know that, but here it's a little different, but still, here also they could find out the large variation up to 10%. Maybe the MU per segment is being changed as per the position of the critical structure or the way the contour has been remodified. This I already told in the challenges. Some takeaways that, like, it takes, of course, the whole system is designed to treat the patient fast. So in that process, I feel like we are missing something which we are already very good on that areas maybe we are bargaining that area and then trying to get into this maybe. And maybe, of course, they are in this very development stage, maybe they can come out with the better things later. The next one is the Radixact Clear RT. This is a nice idea because, as I said, in the cone beam CT and a fan beam CT, the difference is that, like, if you can reduce your width and if you open up very small area and then do a reconstruction, the scatter from the other areas, which are the main contributor for the image degradation, can be avoided. So these guys have started reducing the collimator width and then try to do a fan beam CT. That's why they claim it as that, like, they don't say CBCT, they claim it as KVCT. Clever terminology. So they do a 15 mm scan and a 2270 mm beam scan and then do a CBCT CT reconstruction. The advantage is that because it's already a helical delivery in tomotherapy, so the advantage is you can do a spiral CT because the couch is designed for that. So you can do a full length scan of 40 or 135 centimeters in a quite 30 seconds. That's quite nice. And because, as I said, the scatter is less, they could really get the best low contrast resolution. They're really nice as compared with their existing previous CD images. And they have two modes, the coarse and the fine beam. Coarse mode is almost similar to a cone beam, but the fine mode is quite good because it's a narrow beam and then you do a slice by slice reconstruction of the CT images, so you get a very good image quality. The thing is that, like, these guys have done a very good job in the software side where they could semi-automated the everyday plan. They take the everyday plan images, deform it, plan the contour is deformed, and then do a dose calculation, add it to the everyday set, so that it can really show you what you have delivered and what is planned today. So that's kind of a nice the tool available so to understand what's happening on this patient. And also because they have the synchrony in CyberKnife, so they just added this to the KVCT of Radixact so that they can really try to use that concept of synchrony to monitor the system during treatment with the same image, or you can do another image and continuously when the treatment is going on. You can, if you want to do, you can just do one shot and then see that. So that's again a nice one. And because they have reduced the width of the collimator, they could really get their uniformity, HU uniformity as close to this comparison between the Siemens CT scan with the clear RT. And they could really get the low contrast visibility as well as the imaging noise much lesser as compared with the previous, as well also compared with the true beam system. So noise was reduced by more than a factor of 2, and the cupping and capping artifacts also significantly reduced, and scan time also has been decreased. But as I said, you can reduce the width, but you cannot go to 0.4 mm or 0.3 mm, which you do with the diagnostic scanner. So that's again a catch where they are not getting into it. And also the flat panel detector is not the right one for image acquisition. You need to have a curvilinear detector. So, but these guys have kept a flat panel detector because they want to use a synchrony during the treatment. So, and also the space is not there, so they cannot do a flat panel in a tomotherapy mission. So, curvilinear detector so that's the reason why that also contributes to the image quality. And there is no anti-grad script, where I said just in the previous vendor has an anti-grad script at the director level. So that really adds to the quality of the image. So that also is not there. So definitely, and also the speed is again an issue, because you cannot match up with the 250 RPM. Of course, the image quality is definitely better as compared with the previous one. It can be used for adaptive treatments for at least some of the sites. The next vendor, of course, is just on the way, just got the FDA approval with the Electa. They have designed a nice one, but they are not gone into the ring gantry. They wanted the same existing C-arm LINAC, where they added some features and tried to rework on their hardware to get the better imaging capabilities. They have something called Iris, where they have AI enhanced imaging with a better contrast resolution, with synthetic free imaging, with better HU accuracy. This is again a comparison between a conventional CBT with Iris, with CBC, with the CT scan. Definitely the image quality has improved as compared with the usual Electa machine CBCT, because of this polyquant CT, which is used for basically the which basically used to determine the material mass and the electron density for radiotherapy planning, and used for a CT scan reconstruction, has been implemented here, and they could really get a better AI correction models to get the best quality treatment. Here also they have been able to achieve, both the vendors have really able to understand and get the right one, like that the HU should match with the diagnostic CT, so that the dose calculation can be performed online without the need for a patient to undergo for an offline CT scan. But advantage here is that with this machine design, if you want to do an electron, you can do. You can do a TBI, you can do the next patient you want to do an adaptive, you can do, because the machine remains same. So the workflow is quite easy. You want to do one adaptive, you can do, but you can do a TBI, you can do that. So that's a nice idea, maybe very useful for our country, because we have get a spectrum of patients. It's not like we are not dedicating any machine for any particular treatment. So we get everything we do. We try to do every treatment. So in that process, this is a nice idea when CM gantry gets adaptive modules, and also the quality of the image is as good as like what you see in a conventional one. Again, limitations, if you look at it, the major limitation is the contouring speed, because the algorithms are not that great. Even the dose calculations are better, but still the contouring is an area where we are really struggling. And also because you have an adaptive treatments, it's going to open a lot of failure mode things, like wrong or inaccurate contours, inappropriate margins for the PTV, dose in plan does not match with the intended, wrong or inaccurate contours, plan does not reflect the intent because target is different. So a lot of things it's opened up. So to be honest, it's scary because although you have a clinician, physicist, technology, everybody sitting together, sometimes we look at each other whether we have done a right job or not, because it's like you have to do it in a very short period. So that's difficult to do that. So it opens up a lot of failure mode analysis has to be done in an adaptive treatment setup, because then only you will be able to understand and try to not to harm the patient with such a high-end equipment. And also the one which is coming up is, of course, we have still not reached the deformal registration for the image, deformal dose accumulation, because this has to come, because to be honest, if you want to do a proper adaptive treatment, I should know what I have delivered yesterday. If I know each individual voxels, what I have delivered, then accordingly I can adjust today. If I am not able to understand, every day is a new day, it's not going to work. I want to know how the last 10 fractions, how much is the dose I have delivered to the OAR, how much is the target coverage. Then accordingly, if I can adjust that, I can do a proper dose delivery. For that, we need to have a deformal dose accumulation or warping of dose. So that I think we have not yet reached, but still we are in that direction of cascaded radiotherapy. Thank you.
Thank you for the presentation, nice presentation. So I have a question on basically one of the last things you said. I cannot imagine that you say that adaptive without dose accumulation is useless. That's not what you meant, right?
No, no, no. I didn't say
Okay.
useless. I'm just telling like if we are not able to get it. It's like every day we get the. The idea is like what I have delivered yesterday.
Yeah.
I want to have it on the system today to understand that today's plan I can accommodate that what I have missed yesterday.
Yeah. But do you agree that if you adapt every day with a good system, you can gain a lot also without dose accumulation?
Yeah. Yes.
Any questions?
So my question to you, Dr. Nani, during adaptation, so if after the replanning city, the volume of the ZTB or high risk, intermediate risk, so the volume that has decreased, so it is considered in intermediate risk, or what is the basic of adaptive? Yes, GTV has reduced by some volume, so the rest of the volume is taken as intermediate risk dose, and or what is your point? And other question, in your clinical trial, the stage, some particular stage was taken in that Atrix, Atrix trial in your study?
We are recruiting patients, to answer your second question first, we are recruiting patients who need bilateral neck radiotherapy for any reason. So even, for example, a relatively early stage oropharyngeal cancer patient who will need bilateral neck radiotherapy would also be recruited. So wherever, if it's unilateral neck radiotherapy, then of course one parotid will be completely spared. So there's no point trying to do adaptation based on parotid doses. So it's only when both sides are required, and we've kept a dose threshold. It's a bit of an arbitrary dose threshold, but it's a dose threshold of 25 to 30 gray. So if somebody is getting 50 gray, then we do not foresee that there is going to be much benefit in bringing 52 back to 50. Or if it's 10 gray, then may not be much benefit in bringing 12 gray back to 10. So we've taken a dose threshold. Now that is to make it more selective, because we felt because the Artix trial was already going on, that they are not being selective. They are taking all patients. So some of them may not need any adaptation because their doses are already very low or something like that, right? So we don't know that. So we want to see whether, answer the question once and for all, whether, there's any point in doing adaptive radiotherapy, because we believe in the equipoise that we do not know whether this is actually a good idea or not in terms of
I think it's a very nice setup, Indranil. So my question is, do submandibular glands or oral cavity, does that in some way play a role in your study, or?
Yeah, I think that we have overlooked the submandibular glands. I think that they do have an important role to play, but we find that most of our patients that we treat are patients who are receiving treatment for oral cancers, etc. So their submandibular gland is either dissected out. So this study includes the post-op adjuvant patients as well. So we can't really control for that, but it would be good to see the submandibular gland doses in the context of doing this. Regarding your first question, regarding whether in an area where there is no longer gross disease, whether you should treat that previous area to intermediate dose or original dose or no dose, I don't think that question is has been answered so far. There can be 2 or 3 scenarios. There can be a scenario where in the previous area there is now just fatty space, right? For example, in a neck where there was a node, it has now disappeared, but there's the neck nodal level and there's fat there. Now usually what we would do as clinicians is that because it is not going to cause additional toxicities, we would generally be conservative and try to keep that volume, original volume, right? Because we argue that, you know, there could be microscopic disease. There is a possibility of giving it intermediate dose, and I don't know of any radiotherapy related trials. I don't know, there may be, but I don't know of any radiotherapy related trials where in between the treatment, you know, dose has been reduced to the trial. We know from nasopharyngeal studies that for after neoadjuvant chemotherapy, say for example there was a node and the node is no longer there, you do not need to give higher dose. There is a randomized control trial which says that which has shown that there is no need. But I am not aware of radiotherapy studies. There can be a third scenario where the disease has regressed and now there is normal tissue in that area, normal tissue that you would ordinarily want to spare. For example, in cervical cancer, the disease has regressed and now there is rectum or there is bladder in that area. There, of course, we don't believe that there is microscopic disease inside the rectum or bladder, and therefore we will come out of that area. So it's a clinical decision, and that's how if we find that there will be no additional toxicity or very unlikely to be additional toxicity, we generally keep the original dose in the area.
I think it's a very, very important question in day-to-day practice when the tumor regresses. So I think there are two kinds of situations. So one is, for example, he's talking about head and neck. Most of the recommendations say that we can shrink the GTV but not the CTV, because CTV denotes the microscopic disease, so that stays. We should not tamper with the CTV at all. But then there is another situation in lung cancer where the tumor is pushing the organ, and in lymphomas also there is a pushing of the organ, the lung is pushed to the other side. Now there, and I will show some of the example, when the tumor regresses, we have to come off the normal lung. And therefore it is a very pertinent question whether the tumor was infiltrating the normal lung parenchyma or not. So that is the real, in lymphomas they usually do not. But in carcinoma, in non-small cell lung cancer or small cell lung cancer, it is always a question. But in lung cancer studies, they have shrunk. But in head and neck, most of the recommendations say that don't shrink the CTV at all.
My questions are in continuation to this discussion only, sir. There are two clinical scenarios that we come across. One is both in head and neck, around 15 fractions. There is no anatomical change, but the tumor has shrunk. Now the air spaces have opened up. Otherwise, anatomically, there is no change. Should we consider for adaptive at that point of time, just to crop the CTVs out of the airspace now?
Yeah, you know, the thing is that if you are not missing your original target, there is a great variation of practice. Okay, I can't tell you for sure, but I believe that most busy institutions do not do adaptive radiotherapy in that context, right? We definitely do not, and I believe Dr. Hope is not here, so and I think that they do not either, right? Now, I mean, when we feel that there could be a dose miss or something like that, the target could be missed, that is when adaptive radiotherapy is definitely recommended. Now, will there be a harm if I do the adaptive radiotherapy? Probably not. So how many times you want to scan, what are the specific indications for doing that? If you feel that because of the air there will be significant dose differences to a very critical adjacent normal structure, then of course you might want to consider that. But we saw in the proton discussion that photons, with photon radiotherapy, that is usually not a big consideration, whereas for proton radiotherapy it would be a big consideration.
Similarly, sir, regarding the timing of adaptive, if we are in the last 2 weeks of radical head and neck treatment, and now there are anatomical changes as well as tumor shrinkage, but we do not want to interrupt the treatment. By the time adaptive is started, patient has received another couple of fractions. is that the time to make a new plan when he's left with 8 to 10 fractions?
Yeah, that's a very good question, and we deal with it all the time. I don't know the answer. I think that is why I feel that sometimes the availability of technology makes us take additional steps without really looking at the consequences. If reducing the dose of the parotid or some structure by half a gray in total accumulated dose because you only treated an adaptive plan for the last 5-6 fractions, whether that is worth doing or not is I personally feel probably not, but you know there could be other opinions.
So one last question for sir. You talked about dose deformation in the last. So do we at present have any idea when we are doing adaptive planning, online planning, there would be multiple plannings. How do we see the cumulative dose in the end to both targets and OARs?
Yeah, right now both the, at least CBCT vendors, they are able to give something. MR vendors have completely left with the users. They have to manually add that. We have to keep a separate program for it and manually do it. But CBCT vendors have that. They are able to give some, but that also is not a dose swapping. It is just an addition of this one. So you will not have the particular voxel. It will not represent the real critical organ dose. It just gives you that particular dose, whatever the clinician has contoured, that dose.
Thank you, sir.
Sorry. Yeah, so my question, to pick up on what Dr. Anand was saying about not shrinking the CTV, is that in the earlier era, when we only had rigid registration for replanning images, we mostly took care not to fiddle with the craniocaudal extent of the CTV. But I'm just concerned whether in the era of deformable registration, whether we are actually maintaining that or whether we are even ultimately sort of compromising with that. What's the kind of opinion of the house on that? Because we are coming off the radial, if you like, dimensions, but with the craniocaudal dimensions,
okay.
A, are they important?
No.
And B,
so
are we...
Craniocaudally, no. Because even our imaging has limitations in the craniocaudal direction, because the last slice of the cranial or caudal margin may not be as clear. So I think CTV even in craniocaudal will remain the same, but PTV will definitely change. So
I think with the new detectors which has got 86 centimeters in length, you will be able to get a better degree, because you are taking only 40 centimeters, so you have a 80 centimeters length, so maybe you get a better image.
Indranil, can I just add, you made a comment that most of the busy institutions are not doing adaptive replanning. I disagree a bit, because in gynec cancers, when we have moved to IMRT, so mid-treatment, especially, you know, patients who have large tumors to begin with, so there is always an instruction that goes that after 2 weeks you repeat a CT for adaptive replanning. That is number one. And second, to add to Sai's comment and the question from a lady here about dose accumulation, maybe it's not happening for adaptive, but when we are doing high intensity treatments, for example, SBRT5 fractions or other fractions where there are concerns about, you know, having the dose accumulated. So many times we try to use velocity where we push there, and then there is capacity to give accumulated dose and also in EQD2 with different fractionations. So that was just an additional thing.
I think I take your point, Dr. Supriya. The thing is that I was talking about it in the context of head and neck cancers mostly, but in gynecological cancers, if the tumor shrinks, the OARs come directly within the high dose PTV. So that's one of the considerations.
But in velocity, the dose warping is a big issue. It will do a dose deformal registration, it can do, but dose warping it will not do. So you have to be a little careful on that.
If there are no further questions, we move on to the next topic.
Thank you, sir. Next session is CT-based adaptive radiotherapy implementation by Dr. Prakash. We welcome you, sir.
Good morning all.
So Sai sir, very spotlight in give the explanation, the new technology, how to utilize in adaptive radiotherapy, and Dr. Indanil sir give the very brief idea. So introduction of the adaptive radiotherapy. So as of now, we are dealing with the three umbrella like medical physicist, doctor, and the radiation therapist. The end of the part, as a radiation therapist, the biggest role play in the adaptive radiotherapy, because when you start the point, what are the changes we observe only by radiation therapist, and the radiation therapist give the direction, so decision making to intimate the flag the hand, so give the information as the medical physicist, this is happen to during the treatment, and give the direction for the radiation oncologist. So my talk in basically for therapist, so what should we look on the when you're dealing with the treatment daily basis, but behind little bit I will give the some references. So why do the adaptive radiotherapy, and that stage what to do for the next for the plan for the patients. So little bit talk about the background of the radiotherapy. Most of the now we are moving to new technologies IMRT and VMAT in head and neck cancer, abdomen and pelvis side. Preferable technique, we want to the high precision treatment in the high dose delivery to the tumor, and we want to improve the dose conformity to better focus in the target volume. We require the better sparing the OR, as we know the maximum principle, our maximum dose to the tumor volume and minimum dose to the surrounding tissue. Definitely we want to increase our therapeutic ratio. But when you're dealing with the treatment basis the day to day, we observe that many changes during the treatment process, like what are the first factor is the dose variation. What are the plan initially day and like versus in the delivery, there are some tremendous changes we observe that. Unexpected toxicity are high due to the higher dose to the OR, and maybe sometime not receive the appropriate dose to the OR. We observe that in the toxicity related problem, and misses of the miss of the target like margin and geographical miss of the tumor. So then what is the adaptive radiotherapy? I think morning Dr. Indian sir give the very nice definition, as Jan say, the radiation treatment process where the treatment plan be modified using the systematic feedback of the measurements. So adaptive therapy allows modification the treatment plan offer, like first point is anatomical changes, like common that is the weight loss, tumor shrinkage, alternative muscle mass, and the change in the flat of the patient. Another important point, that is the biological functional changes, the variation in tumor biology such as hypoxia, we found that. But main goal, the accurate treatment delivery and minimize radiation healthy tissue. So in again the IMRT and the VMAT treatment delivery, so we observe that the precision of the target can sometimes miss the part of the tumor, may lead geographical miss. Imaging may not show the full image, the spread of the behavior of the tumor. We observe that suppose when you the abdomen tumor, we take CBCT, we cannot identify clear imaging due to the air gap and then something the good, not good the quality of image. We cannot identify the clear imaging with the CBCT also. The tumor and the normal tissue can move change during the treatment. We observe that uncertainty various type of inter or intra fraction of the motion, and even with the detection of the response of the tumor, weight loss of the tumor, weight loss of the on the treatment, and we define the action level, that is when and how to often and margin of the dose. But definitely high dose to the near importance increase the risk of the side effect of the patient. So that is one of survey done by the Dr. Rahul Krishnamurthy in Tata Memorial Hospital. He circulated entire in India, and we participate like radiation oncologists and medical physicists and the radiation therapists for the adaptive radiotherapy survey. And he common side the feedback receive the feedback from the maximum people are doing the head and neck cancer 92% in adaptive radiotherapy, lung 52%, and the pelvis is the 44%. So common method why doing the adaptive radiotherapy, the response given most of the tumor regression, offline planning they are following the for target volume margin, and the offline for the replanning for the target and the organ changes. That they are criteria for the replanning. But again the biggest challenge, the lack of the equipment, then we have lack of the training and the support, and we know the busy schedule, the more than 100 patients per day, it is a challenge for the doing this activity in adaptive radiotherapy. So this survey say that. So then coming to a point, why is adaptive? The very important that is tumor shrinkage and the growth, changing the tumor size and the required planning adjustment. Patient weight change, impact of the immobilization and positioning. Suppose when you head and neck treating the patient and the gap between the orbit and the skin, when you align the patient, maybe the sometime we observe that the setup error is increased and it is impact of the treatment accuracy. Organ movement, suppose we are treating with the CS cervix patient and the prostate patient, we feel about the bladder, bowel, and the respiratory motion tumor like lung position affect the treatment delivery. So that scenario, we require the adaptive radiotherapy. Recent study, that is I want to highlight it, this nasopharyngeal tumor, the case, these are the many authors quoted that when to trigger the adaptive radiotherapy and what is the time factor they are following for adaptive therapy. Basically, yes, we want to the very good removal control, we want to the benefit of the adaptive radiotherapy with the dosimetrical parameter and definitely outcome for the patient also. But we observe that they observe that in the trigger point like body weight loss more than the 10%, then significant increase the high dose to the neck, the influence of the nodal mass, increase the overdosing the spinal cord. So there are plenty of number of the scenario we required for the adaptive radiotherapy and they what timing to suggest to do the adaptive radiotherapy. So again this morning most of the people and yesterday also talk about the head and neck cancer, that is when you treating the pituitary gland and to increase the risk of the xerostomia. So this is our initial plan. So after that the actual plan delivery without replanning and adaptive planning, so they suggest that to decrease the risk of the xerostomia. So we observe that when you doing the simulation as a radiotherapy technologies, when you take the CS cervix patient, the prostate patient, so when you take the scan and acquire the CT scan, we see the rectal gas is more than 3 centimeter, 4 centimeter. We cannot further the scan, but those are the acquiring the rectal gas variation in your CT scan the planning. So definitely we increase uncertainty of the setup and we observe for that increase the risk of the biological and local failure, the patient with distant of the rectal volume in the planning city. So make sure when you are doing the CT scan, that is very, very important, measure your rectal volume. So keep your eyes open that time when you are acquiring the CT scan basically in this particular case also. So I think the morning the Dr. Indramil sir very clearly that when to do adaptive, there are the different the strategy we can apply, like one is offline adaptive between the fraction, online adaptive that immediately prior the fraction and the real time. So we can do the adaptive as per your institute and as per your department policy. So depend upon the time depend also, that is a fixed interval and the trigger interval for the adaptive radiotherapy. So what about the fixed interval? So fixed interval, suppose you are plan the 60 grain, the 30 fraction. So we can predefine. So we want to after 15 fraction, we review the CBCT and we judge that. So whether is go for the adaptive planning or what are the parameter we set your department accordingly. Then we do for the further for the treatment for the adaptive radiotherapy plan also. Trigger imaging. So we predefine means after 5 fraction we review, we check the imaging and we certain parameter like whether the tumor changes or OR shifted, the setup error increases or anatomy changes or dose deviation. So after 5 fraction we trigger that and we just quantify whether it's really worth for the adaptive for this patient and we accordingly adjust the existing plan also. Then now adaptive radiotherapy exploring the clinical reality in the future direction, because in the morning session the Dr. Subramanian Sai sir told that the time based, like time again if you see the OR, the consistently change of the cardiac breathing and persistently. Suppose when you take the CT scan images in the prostate, but after several seconds the gas come to in the prostate also. So the organ failure that is really impact of the treatment accuracy. So again an adaptive strategy is very important, interfraction changes and the interfraction changes. So these also we can do for your clinic also. So offline review, like offline review strategy means like this is your planning CT images and your treatment session. So each fraction using the offline tools we can go for the offline review. verify all the imaging section. Suppose there is no changes, we can go for the treatment. But if something is happened, like what are the department policy we set prior of the adaptive treatment planning, so we can go for the when it changes, then do everything for rescan, resimulation, and the physical dosimetry, and the patient specific QA, and go for the adaptive radiotherapy. And now online adaptive therapy nowadays, MR-Linac is available for the specially and adaptive radiotherapy in ethos. They can do on couch, on the adaptive radiotherapy, like each fraction we take the image, verify the image, and suppose if you have any contour change or any variation, they do immediately on couch treatment procedure and validated plan do for the adaptive. So this is very nice online adaptive platform for the radiotherapy also. So yes, if you're the moving to the adaptive radiotherapy, we require the technology. I think Sai sir will give very good explanation. So which techniques and which technology can performance in adaptive radiotherapy. So, but when you're dealing with the adaptive radiotherapy, we require the good imaging quality. Suppose we have the, but if we have the poor imaging quality, we cannot perform we cannot delineate the target volume, what is the previous we acquired the CT scan images, and we cannot use our CBCT image for your planning. But we can just identify quantify whether is required for the patient using for this volumetric image like CBCT, your FAM-BIM CT, MRI, and the CT images and MRI images. So we can quantify for the any changes or other for the previous plan and actual plan of the actual treatment process for the further adaptive planning also. So I want to just highlight in head and neck cancer, we observe that as a technologist most of the times this is head and neck patients, and we observe that the decrease of radiation, decrease the volume of due to the good response of the radiation of the patient. So again, decrease the volume. So the biggest problem, the weight loss, and again our mass is not fitted appropriate in the head and neck cancer. So that is, we observe that is the more than 5 mm gap between your ORFIT or the PTV. So we change for the adaptive radiotherapy also. So again the pelvis region, so the changing the bladder and rectum volume. So initially we can see this is a lot of gas and it's close to your PTV, but we observe that the bladder volume changing over the treatment positioning. So we observe that 3 days, and if you persistently the same problem, and we change our plan modification for resimulation and readaptive for plan for this particular patient also. So common situation in like head and neck and the lung cancer and the pelvis, most of the in head and neck, as a technology should know the tumor shrinkage, weight loss and affecting the immobilization, lung tumor, that's a tumor movement and due to breathing changes, and the pelvis, most of the organ feeling affected or the coverage is not properly, we have to observe that in the situation also. So in head and neck, there are the certain parameter we have to strict either pre-treatment parameter and on-treatment parameter. Pre-treatment parameter, like suppose when you're doing the simulation, we observe that this patient may be required this adaptive radiotherapy after several fractions, like large or primary nodes, large serum or fluid collection, significant loss. So we can observe that. Sometimes the flap we can reduce, they can be observed that. Unsuitable, like unexpected error is more than what are the tolerance level beyond the variation translation error. So we have to think about that adaptive, and mass is not fitting in the treatment delivery also. So at this, here is our radiation therapist's biggest role to the triggering point. So like the number is the tumor shrinkage, we have to observe that the appropriate manner. Gap or immobilization, whether is more gap, so it is again uncertainty of the treatment delivery. Organ movement we have to watch, and the good communication, because yesterday I treat the patient, maybe next day the other therapist treatment delivery. It should be communicated one therapist to other therapist, and also inform the teams and the patient also. So again we have to recognize in head and neck cancer head and neck treatment, because we can see this is the head and neck patients, and we observe that is a gap, lot of the gap between the patient's skin and the ORFIT. So again increase our setup accuracy. So then we have to again priority, which one is a priority and moderate priority, because yesterday Dr. Indran gave the priority of which one is organ is important when you're dealing with the treatment and coverage or not coverage. So in the common situation, why is the PTV changes? Because we observe that tumor, the regression, patient setup variation, and surgical flap. So we can see this, the gap, a lot of the gap between the patient, the skin, and we observe that the changing the factor and changing our the setup errors. And sometimes other factor also impact the increase our uncertainty, like poor nutrition and the weight loss also. So this is a common, we observe that the planning CT image after 5 fraction, 10 fraction, and the 15 fraction. So the tremendous changing of the patient, the body contour, and we required for adaptive radiotherapy. So weight loss, there is the study of, they are doing the 72 patient receive the IMRT, and medium dose is a 74 gray, and they are doing the concurrent RT and doing the CBCT. So out of the 72 patient, 15 patient we required the adaptive radiotherapy, and they observed that weight loss in 7.8 kg, and average body volume is 7% is decreased. So we also in our clinic we observe that this similar patient is initially planned, and we can see so weight loss in initial is 62, and the almost 6 kg is reduced. So here is our technology, the therapist role is comes. So sometime you have department, the staff nurse, we have to ask the staff nurse, because we significantly physically we observe that the patient really significant with the weight loss. So we can ask the patient what is your vision initially or now. So we can tell that our radiation oncologist, this is the tremendous change of more than 10 kg weight. So we can trigger point and we can intimate. So we have to do for the next for these patients also. So this also the same case, we do the 2 times of the adaptive, because the changing the volume, change of the weight loss, that we are doing the 2 times of the adaptive radiotherapy also. So we also do another case, the resimulation during treatment. Initially, we, the case of larynx, we deliver the dose in 70 gray, and mid of the treatment, the entire the tumor very good response, and we impact our the weight loss and everything. So we do the replanning for this patient for the adaptive radiotherapy also. The change in critical the structure, like the parotid is very important organ, and this author quote that the loss of parotid volume is 0.2 cc per day, and by end of the treatment loss of the parotid almost 28 gray, we observe that. So we require this, we observe that whether is required this patient is adaptive radiotherapy based on this the loss of the volume of the parotid critical organ. So another the study that doing by our radiation therapist in UK, and they observed that the 21 to 65% we required the adaptive radiotherapy plan because of the weight loss, edema, and tumor shrinkage. But they are following adaptive and online, both are the quantify the dosimetric and the replanning for the volumetric changes for they observe that. So another side is the thorax region. We also the observe that is initially the GTV 115.2 and drastically change of the down of the volume, and we require for this adaptive radiotherapy for this lung case also. We have certainly last week we treated in our department the liver SBRT. So after initially planned this, okay, we mark the planning target volume, and the second fraction we observe that the target is entirely missed, because suddenly we can observe that the anatomical changes we found in the CBCT scan, and we cannot treat the patient with SBRT when you shifting your target and the changing the anatomy. So we again come back to your CT simulation, do everything. So we observe that this is a challenging happen in the SBRT case also. So another case in the during of the lung case, the changing the volume almost 41% in the 6 weeks, and they acquire the 4D CT scan, but we observe that in the 50% of the tumor show the more than 40% the volume of the reduction. So they suggest that repeat the 4D CT scan recommendation to avoid the missing the tumor. But again, if you do how many times you do the 4D CT scan until increase of the dose to the patient also. So another site, that is a pelvis site. So we initially plan with the bladder, but we observe that bladder is fully in the CBCT and organ also motion. So we observe that there is required or not required, and the technology again challenge whether it's a treat or not treat, because the bladder is pushing the organ, and your CTV is missing during the treatment. So we observe that another case, that is the tumor location also change, anatomy also change. So we require this particular patient to evaluate for the further treatment of the fraction, whether go for the adaptive or not adaptive for the changing the challenges of the adaptive also. So in abdomen and pelvis, others, when you losing the weight loss, the entire the body shift and the volume shift, we can say this is the very challenging case, the organ fully, the changing the positioning. So marker, shift the marker and weight loss due to the weight loss also. Then initially we do the full bladder, but after treatment the positioning, everything change, bladder and rectum volume. So we cannot treat this particular patient in that the fraction also. We have to immediately intimate the prior of the consultant, this is happen for the next, for the implementation also. Then we change the bladder volume. Every day we can observe that in CA cervix patient, the bladder volume change, your uterus position change, and rectum position change, day-to-day variation. So we require this evaluated, what can do for the stable bladder or stable the rectum positioning. So we required for the better solution, either go for the replanning or adaptive planning for this particular challenging case also. Then another very challenging case I have taken for the net is the prostate and the rectum case. So initial rectum is okay, but when you doing the CT scan or the CBCT image, everything is mismatched. Distant tumor, distant rectum we cannot match because the volume is increasing. But another same case in the for bladder, rectum, prostate, everything is mismatching. So as when you dealing with the technologies and doing the IGRT, so it is a decision making is very tough for the particular case. So when to watch, because if you match the prostate, everything go to the in the PTV and we miss everything. So that is a very tricky point for the therapist when the decision making also. So then adaptive radiotherapy in the cervical cancer, the cervix cancer, that is a tumor shrinkage. So initially this is a plan, and after 3 weeks the tumor tremendously shrink, and we do the for adaptive planning for the better OR sparing also. So if you, yesterday our Dr. Ben regarding the model, so we changing our due to the bladder volume, your uterus position changing. So they are acquiring the 2 scan, like full bladder scan and empty bladder scan, and they predicted like how much uterus positioning change to your bladder volume. So accordingly we can define your model or how much motion to our uterus move. So accordingly to generate the plan, and we decide the plan which one accordingly to decide over the margin, and we treat the plan for particular this case also. So then coming to our bladder cancer, if you have the feeling with the bladder cancer, okay, this is a 500 ml water fixed, but if you're daily changing, bladder is okay, but rectum is pushing your bladder. So we require this strategy when you're doing the CBCT, so everything mismatch. So there is the bladder study, they are doing the either 2 plan, like full bladder and empty bladder, and they have the library plan like the small PTV, medium PTV and the large PTV, and accordingly to the bladder volume, they can set and they can treat the before in the CBCT, verify everything, and then choose the plan of the day for the bladder cancer also. So similarly in the rectum, so we can see the full rectum and the empty rectum with the full bladder scan. So we give the different margin, and accordingly to the decision as the therapist, so which one we plan to select or PTV, we can do the daily adaptive for accordingly to your plan base decided. So similarly we observe that this is in the prostate cancer, there are the lot of problem, the gas and the rectal variation. So what can do for the simplest, because people are doing the lot of thing to give the medication, give the proper diets, but we are doing our department initially, I'm doing this study for the comparison of the rectum volume, the variation for the morning versus the evening patient. We take out the data, we draw all the contour in the CBCT images in the rectum volume, and we analyze that the morning and the evening patient, and we got the very good result in the 50 patient in the morning versus evening. The rectum volume variation, we got the 16.57% in AM, and the PM is the 24.35% in the PM. So we get the morning session, we get the very good, the stable rectum, the morning session, the treatment of the prostate cancer, and we changing our practice in our department. All the prostate question we shift in the morning treatment, and we get the less stable rectum in our clinic also. So again, as a role of radiation therapist, we are the team like radiation oncologist and medical physicist and the radiation therapist, because everyone's together, the communication very, very important when you implementing the adaptive radiotherapy. Because there is another paper, is Yath give the very good the evaluation role of the technology and therapist in adaptive radiotherapy. We have to think about the work in the predictive and the proactively. So similarly, we can implement our practice. We have to do the work as a proactively. So what are the imaging? Like we observe that, and we can define our role. So what to decision maker? We require the skillful, the technologies when adaptive in the strategy in a department. So as of now, the technology, the complex treatment process, we require the RTT must training very, very important. So as a clinician, as a medical physicist, they are doing the fantastic job in the dosimetry room and the planning room, and the doctor also doing the contouring. But sometime, what are the plan we are generating for the patient? At least sometime the tricky situation, we have to give the intimation of the radiation therapist at the day of the treatment delivery. So they also make alert. So when it happen, this patient after 10 day or 15 day, maybe it's required adaptive plan. So they also alert, yes, this is alert point for me, the more crucial like that. So training and recognition for the patient anatomical changes. So like we have to see the target coverage, dose distribution, the managing the important changes near to action, daily imaging assess very important. Suppose if you not identify, if you not quantify the good imaging, if you are not using the good imaging tools, we cannot identify the clearance of this particular imaging severity. Appropriate or misalignment of the patient position, that is impact of the treatment delivery. So we have to tell that the medical physicist and the radiation oncologist teach to sometime the radiation therapist also. Then we require the triggering, need to identify the trigger, when to trigger, when to stop your treatment, and the patient communication, very, very important. Sometimes we have to, patient rapport and the therapist rapport is very important. We have to ask the patient, sometime patient bladder volume, whether the patient is adequate to take the bladder or not, water or not, because sometimes patient, yes, there is a 45 minutes is over, my bladder is full, but when you take the CBCT, bladder is empty. So that is communication is very, very important when you're doing this such high treatment delivery. But nowadays, the technology's role is more and more for the new modern technology or the new age of the radiation therapist, because we see the 2D era to now we come to the 4D era. There are a lot of changes in the complex treatment process, like the technology is more in the advanced treatment process, the multi-imaging modality, the QA parameter, patient support, the education, and offline really. But we are the day first of the technology with the patient, every day the patient, what are the changes we are finding, we are playing the biggest role in this big journey of the patient outcome also. So we have to, as a radiation therapist who was sitting in this auditorium hall, we have to adapt the new technology in adaptive way. So that is our evolving role. So at least what are the technology come, suppose my center is having the TrueBeam and some center having the new technology, we have to adapt, we have to learn, and we can implement our department, your practice. Means at least continuously improve the stay update in industry trades. What are the trades come to the new technology, we have to adapt, safely implement the new techniques and apply the skill accurately. The mentor team, a member with the priority treatment center, at least when members the train your department, so they can teach the other therapists, adapt the new technology, enhance the patient care, that is very important for us, and focus on going the learning, stay ahead the new fields. That is for the evolving role of the new technology adapting for the radiation therapist field. So again, there are the multi-modality knowledge, because fusion and the registration, nowadays the PET-CT images, MRI images, and the CT scan images, and the linear axillary images, we have to understand, because nowadays the technology role is more and more in imaging. Because if you not identify clear the imaging or the registration, the fusion while delivering the treatment, so maybe lack of the treatment delivery also. We have to understand what is the location and the CT MRI. When your doctor is delineate the target volume and the CT scan MRI, technology should be understand the thoroughly knowledge of the MRI imaging also. What are the IGRT protocol where you implement, it should be go to the like SOB manner. Are you following or not? give the training for the IGRT protocol, like decision maker. Detection of the anatomical changes. Suppose if you have we observe that, we should be understand whether is going to the finding the changes also, and alert for the decision making. So as a technologist, we have to follow the step in the adaptive radiotherapy. Technology's role in the patient positioning, image fusion, like image assessment and manual adjustment, detection anatomical changes, plan of the day selection, image approval, and the QA verification, the treatment delivery. There are the several steps we have to go to the step, and we have to follow that the safety every point of view when you're dealing with the next step also. So as of now, I want to highlight that is when to alert the radiation oncologist while the changes. Number one, we have to follow the traffic light, that is to see, to verify, and to treat patient. So like what to see, the check, the setup or imaging, confirm your patient alignment, and proceed after verification. So we have to ask on the couch when a patient, we ask whether is CTV cover or the GTV is not covered within the PTV, then accordingly to choose as a judgmental over the decision maker. So another example, suppose this is a case of head and neck case. So the tumor changes of shape changes, we have to alert immediately the prior of our consultant. So the weight loss is another example, lose the cast. Then sometimes we observe the toxicity, we have to observe that daily basis when increase the toxicity. So immediately alert for radiation oncologist in like head and neck also. Sometimes the breast is a moving target, so PTV is not covered in the CBCT. So what to do for in this scenario? Then the bladder position, whether it's match or changing the shape. So we have to alert in the radiation oncologist also. So adapting the new technologies as evaluation, as AI impact in our radiotherapy. The therapist training is very important, critical skill, beyond the push button, never like we have to more role in emphasize and proactively work in your judgmental in the research activity, teamwork and collaboration very important, and the better care for the patient care also. So last slide, my conclusion for the adaptive radiotherapy, better outcome. So adaptive radiotherapy help protect the healthy organs and ensure the cancer get more treated accurately with the help of the new technology and the new strategy. Teamwork is very matter for the when you implementing our the plan of the day of the radiotherapy, good efforts in the good teams. The skillful staff is very important because training and keeping the team motivated is super important. Good communication, the clear and open communication with the team and the foundation of the success. And exchange exists like adaptive radiotherapy can take a lot of time, efforts, and resource. Hope to future the new technology and the research will make adaptive radiotherapy easier and more efficient. Yes, as a patient preparation and positioning, the accurate setup is essential even we have the new technology or the modern technology. Thank you.
Questions? I would really be happy if some of the RTTs in the audience, stepped up and asked questions.
I had a question mostly to you and Supriya as well. Regarding management of the rectal volume, we don't normally do anything actively in this country. I mean, the timing of the treatment is quite interesting, what Prakash showed, but I do know that in Europe they do use flatus tubes and things. So where do you stand on that? That's the first question. And the second question is, in your departments, how have the RTTs been trained up in adaptive radiotherapy practice in terms of the clinical eye?
Is it working? Yeah. So in our clinical practice, we started it actually as a part of research protocol 5 years ago, where for GYN we started with piloting plan of the day approach. It's not used in our clinical practice, but within a research protocol as a first step. And what we realized is that for patients, the major problem comes because of bladder filling rather than rectal filling. And if you look into the series of publications from our institution, we realize that as far as rectal filling is concerned, before starting radiotherapy, 3 days patients get Cremefen or Dulcolax. And after that, we do not bother much about rectum because we use ITV for far majority of our routine clinical patients. Despite using ITV, bladder is sometimes a problem. And when on weekly CBCTs, we generally as staff review all the CBCTs, like on machine RTTs or some of our resident doctors review. So offline reviews we do once a week, and that is a trigger that we decide if a patient needs to have a change in protocol or change of margins. And overall, only 15% of our patients need adaptive replanning. Second strategy that we use is not for the rectum, but in clinical protocol plan of the day. So there are 3 cohorts of patients that was tested and published, that up to 40% of your patients are actually okay with the margins that we use, and others may actually need either reduction or increase in margin. I don't know whether it answers your question or not.
Rectal filling is a random error, is a random process. So in general, we would not do adaptive planning for prostate cancer. I'm talking from the perspective of prostate cancer. We would never do adaptive replanning for prostate cancer unless we realize that our planning CT scan had a systematic problem. Like if we have a very distended rectum, and then by mistake, because we do have a protocol which prevents that from happening, but if it did happen and we found that systematically there was a problem, then we would rescan and replan the patient. But in the usual scenario, for rectal filling, bladder filling is not that big a deal for prostate cancer patients. So in the 2 different scenarios, there may be an issue.
Yeah, just a few points. In our department in Manchester, we have an MR Linac, so we do our adaptive strategies on there, and then on our conventional Linacs or our C-arm Linacs, we don't do adaptive. But managing the rectum is a very tricky thing to do. For more inferior sites like the prostate, we would do a daily microenema in a lot of departments, as well as a low fiber diet in advance of radiotherapy to kind of try and prevent it. We're a lot about trying to prevent it as opposed to trying to correct it online, because that can be really tricky. And then for gynae, for treating further up, will then involve laxatives as well. But sometimes laxatives can cause a little bit more gas and can be a little bit more tricky as well. So it depends on the patient. But yeah, those would be our strategies. And training of RTTs, I'll be talking about that in my session later.
I want to ask one question, that in a single course of head and neck patient, how many times normally you go for re-mask making?
So if you persistently change in the volume or weight loss, so while one times we change our mass, the new mass.
Okay, and I want to ask Dr. Bain, as this problem is more severe, means more sensitive in proton therapy center. So what is your observation about re-mask making?
So you're asking me, right?
Yes, yes.
Sorry, let me look. Sorry. So, I mean, this is not massive, undoable. I think for the, I've never heard in proton therapy where we adapt more than three rescannings.
Okay. No, we are doing rescanning or check scanning, but with re-mask making, how many times we are doing that?
Oh, no, the mask, I mean, if we almost always, if we rescan, there is a new mask.
Okay.
In head and neck you're talking about, right?
Yes, yes.
Yeah.
Okay.
This is an add-on to Jyoti Roop's question. For proton gynec, patients are undergoing resimulation on an average 3 times during the course of treatment.
No, my comment or question on that is that to what extent do you think that these changes that you're seeing are gradual changes in a particular direction as opposed to random changes? You can have a day when today the bladder filling is too much, or today the rectal filling is too much, or today I mean, are you doing it based on just response assessment, or are you, between day to day, there are day to day bladder rectum variations without any change in the tumor? Would that prompt a replanning from your side?
I'll answer this in two parts. One is for photons. We do not require in our routine planning for gynec, for bladder and rectal filling as much, because we use ITV approach, and on clinical protocol plan of the day, most of the gynec replannings are tumor shrinkage related, where it shrinks and then anatomy changes. And for proton, it is all, because even slight weight loss, because of the range uncertainty, here it's because of bladder, rectal, weight shrinkage, tumor, everything.
Supriya, if you're saying all that, I mean, it really, I think there is a real need for daily online adaptive for protons, right? I mean, you have so much changes in anatomy in these patients, right?
We don't have huge orders of ethos like yours. We don't have online adaptive. So we have to do offline. And protons, you can ask Prakash, he gets frustrated with me. He would like to have online adaptive every day for protons. But the answer is we don't have, in our institution, maybe Dr. Anand or other people who have ethos or other platforms can say what they do for GYN. If we had it, we'll do it, but we don't have it.
Yeah. So I just want to add from our initial experience on MR-Linac for prostate. So there is a lot of problem with the bladder and rectum almost daily, and so most of the time it is first 3 days that we have to monitor, because everybody has different bowel and bladder habit, and so first 2-3 days are very, very crucial. And the first day when we shift the plan from CT based planning to the MR based planning, that is the maximum deviations we see, because CT based planning we have done before, and after 3-4 days patient comes for planning. Although we do bladder protocol, we give laxative, we give directions for passing through, still I hope you will also agree with me, the first day is very bad, and in few of the patients we didn't treat the patient on day one. We went back and we corrected everything offline before we start, because that is the maximum variation. And the second thing we see, that after first 2-3 days, then the rest of the, say, a 20-day plan, things are much more stable. Any comment from you?
Yeah, we don't see that so dramatically on day one with our patients, but kind of similar to what I said previously in one of my talks, that you can't IGRT your way out of a bad position or a bad setup. It's the same thing with ART. If your bladder is excessively full or your rectum is excessively full, there's no point adapting. We would get the patient off the bed and try and amend it. But yeah, maybe there's more of a role of like patient education, and maybe there's something more in there potentially to try and cut out that kind of that bottleneck at the first fraction. But it's not something that we kind of particularly notice, but it's more random for us. So it might crop up on a random fraction, maybe due to hydration levels before starting drinking, or yeah.
So we do see a lot of changes in the seminal vesicles. Seminal vesicles, we see a lot of changes, and did you do recontouring, replanning, and treatment? Nothing. We cannot do anything because the margins, it's out. So every day, contour, plan, treat.
We have two methods to adapt in MR-Linac. One is called ATS, adapt to shape, and the other is ATP, adapt to position. But in prostate it is always ATS, and so depending upon how much time you have spent or experience you have on MR-Linac, the time spent nowadays is 40 to 45 minutes per patient. Some people say 1 hour. And if you are caught in the vicious cycle of you recontour, you start the treatment in between, the bladder fills more, you come back, you do another ATS, then that vicious cycle can go on to one hour. So I think I take her point, I think it's a lot of more patient education if you want to finish treatment on MR very early or within 30-40 minutes.
I'm just wondering, after hearing both of you, that in CT we cannot make out those details. We treat the patients with limited margins. They have good outcomes. So in terms of outcomes, does all this effort matter? And I don't know the answer to the question. I'm not asking it as a sarcastic question. I really don't know. I mean, if we look at our patterns of failure in a patient who has seminal vesicle involved, it's 90% of the time distant metastases rather than local failure. So is this, if we see too many details and we want to act on these details all the time, is it worth the effort? And it's not just our effort. The patient also has to lie on the table for 45 minutes. So
I can tell you the local control wise, we still have to have data whether MR-Linac gives better local control compared to CT based. But I will show you Mirage trial. It is a randomized trial which has shown a reduction in toxicity.
And
so I think we do, if you see your linear experience, we do see a few patients who have higher rectal toxicity what we would have imagined. So that toxicity part, I would say, is better taken care of. Yeah. So you can do margin reduction only if you have a very good imaging. So I think when we talk of margin reduction, we just can't do offhand. We have to have
there has to be a gating, or there has to be some
imaging.
kind of it's not replanning. It's so the time that you're spending is in replanning, whereas a 2 millimeter margin with a gated stop may be a faster solution.
So
we can have this debate after the MR talks, because I think that will add context to that's right. Thank you, Prakash.
Thank you, sir.
Thank you. So we'll take a quick break and we will be back. Thank you.
Welcome back, everyone. Now, next session is MR-Linac based adaptive radiotherapy technology by Dr. Sai. We welcome you, sir.
Sorry, I was late. We start with why MR-Linac. Of course, we know that MR has an excellent soft tissue contrast. There is a possibility we can do adaptive treatment because of the great soft tissue contrast, and maybe we can do a dose escalation. Real-time monitoring is possible because MR is ideal for gating, because you can do at least 4 to 10 frames per second. So real-time gating is possible because there is no extra dose to the patient. So definitely. Functional imaging is there. You can do a diffusion weighted imaging, and you can do an ADC map, and then do based on that you can do possibilities there. And you can gate and track also. Of course, it opens the door for dose painting. We are all talking about dose painting, but we have never reached that. But this could really open the doors for that, maybe having the key. And this is one of the image which we have taken in our institute, and which clinician will say no to this such a quality image, because it's a just 2-minute MR. T2 sequence, it's very clearly seen seminal vesicles, prostate, and then very nicely difference the contrast difference is so good. Of course, we know that, that's an advantage. But only thing I want to highlight here is just a 2-minute MR. So that's a nice one. So we use everyday prostate treatments, 2 minutes MR, and then plan on that, contour on that, and plan and treat. Why we need MR guidance? Even if you look at the other side, the CBCT guidance, you have a CBCT guided treatment, adaptive treatment, people who are doing that, they also do a weekly MR and try to use the same couch, transfer the patient, do an MR, bring it back to the CBCT guidance and use that and treat the patient. This is one of the examples where in Heidelberg University they are doing this. And there is again a macula study where University of Switzerland, they use the conventional C-arm LINAC for adaptive treatments. They also use MR in the next room and transfer the patient and do an MR, and they could find that some dosimetric benefit and some genitourinary and gastrourinary and genitourinary toxicities are less. Just to be answered the last session question, like we also asked the same question to our clinician. We are doing so much of labor intensive work, is it really translated to the patient or not? So we did totally around 48 SBRT prostate in our clinic, and so the clinician did the study of toxicity data, and he could compare it with the CBCT based treatment, and he could really find that, I don't have the slide, and my clinician was presenting that, and they could see that he was pointing out that more of the patients are in grade 1 than in grade 2. So that percentage has reduced, so that gives some kind of a feel that, okay, whatever we are trying with the MR-Linac is translating to the patient. Coming to the MR-Linac systems, technology, there are two things, sorry for the image, one more is missing here. You have MR Unity and View-Ray. Unfortunately, these are the people who started the MR-Linac, and they have shown a lot of good results, but because of some financial issues, this has filed the bankruptcy. So, but if you look at the technology point of view, you have an MRI, you have a LINAC. So LINAC has a lot of metallic piece, and MRI is a high magnetic field. So it's going to be a problem because these two guys are like South Pole and North Pole, and they have to work together in one room. So one will cause a problem to that, like in MRI, presence of MRI will create a problem for the beam generation because electron has to be accelerated in a guide. So that's an issue. And beam penetration, beam has to go through the cryostat and deliver the patient to dose to the patient, problem. Then because of the beam penetration, you have a scatter. So this scatter can cause a real problem to the system. So, and also there is a problem of a Lorentz force, because I'll come to that, like, when you have a 9th standard physics, when you have a charged particle in a magnetic field, it tend to deflect. So by a left-hand thumb rule. So that's again an issue. And also the other way around, MRI can cause a problem to the MRI, radiotherapy can cause a MRI to problem to the MRI. Like, MRI is going to listen to every small RF radiation from your body voxel. So that kind of low RF signal is going to listen. So it's definitely going to listen to the RF radiation from the LINAC. So it has to be isolated and protected from the LINAC RF system, so that's going to be an issue. And also the LINAC is going to rotate around the MRI. So usually MRI, whenever there is an MRI installed, we don't allow even the cars to move that close to that area, because it really causes a lot of eddy currents, and it creates a lot of noise which can really affect your image quality. So you're going to have a LINAC which is going to rotate around the MRI machine. So that's going to be can create an image field inhomogeneity. So these are the two big problems. And this I already told you, like the Lorentz force, when an electron is getting more deflected, depending on it goes with the strength of the magnetic field. Higher the strength, the more is the deflection. So this has to be modeled and then incorporated in the planning, then only the dose accuracy will be better. But again, some issues are there, like whenever the electron travels from the high density to the low density, it tend to come back because of the electron, we call it as, because of the magnetic field, it tend to return and deliver the dose. So there is a possibility that if you're going to give a single direct feed treatment with the MR-Linac, you're going to have a lot of trouble because the exit dose is going to be higher, and that's why we tend to give more and more large number of peels so that it gets diminished, so that we don't have to worry about this effect. Coming to the technology, View-Ray, of course they are not there, but just to give you this one, like they are quite clever guys, because They didn't go very high magnetic field. They get magnetic field little lesser, 0.35 Tesla. So that's nice because the electron return effects are less, Lorentz force is less, so automatically easy to manage and easy to shield. So all these things are big advantage. So that's why they could, even the concept of MR-Linac come from the other vendor. Bure could make it clinically available much earlier than the other vendor because the other vendor was working on a higher Tesla than this one. This is a 70 centimeters board. They have an advantage with the couch can move translation movements, so that's again an advantage with that, with 600 MU per minute. And MLCs are similar to what you have seen in the ethos, where you have a stacked MLCs with the we field width of effective field width comes up to 4 mm, and the field size 34 by 27 centimeters. No ODIs and no lasers. But just to give some information on that, like as I said, like you have to shield the Linac from the MR. In Bure, it's not a big issue because it's just a 0.35 Tesla. So if you can, the RF radiation from the any system can be shielded with the help of a copper. So they have a copper pipes covering the entire axe guide coated with the carbon fiber, because copper, of course, transmits some of the RF radiation, and if there is any crack developed, so it can come out. So, and RF radiation can be very well absorbed by the carbon fiber, so it's coated in that. And sorry, an image is missing where they have covered the machine with that pipe. But having said that, you have to create almost like a zero magnetic field in the accelerator, because accelerator contains the electrons. Is the place where the electrons are accelerated and made to hit the target and get the X-ray. So you have to create that low magnetic field very close to the MRI. So this is done with the help of a high permeability material we call it as mu metal. Big metals are kept around that so that the magnetic field tends to get reduced, and automatically the accelerator is saved from that. I'll show you the picture on that. This is again the difference in what happens when you have a magnetic field and if you do a dose calculation. Because what happens, as I said in the beginning, the electrons tend to get deflected with a high magnetic field. So in a normal radiotherapy treatment, you have a high energy photons. Photons has no issues, but the problem is that like when the photon hits the patient, the electrons are produced. These electrons are responsible for the dose deposition. So they are going to tend to skew towards one side, and that has to be modeled. And it will be more pronounced, as you see in the left side, in the right side, as you could see that it's more pronounced in the low density, high density areas, and it has to be modeled, otherwise you will be definitely delivering a wrong dose to the patient. And this is again, as I said, the Bure has, the studies from the Bure system, and clearly showed the real benefit, and that gives the motivation to use MR-Linac. Coming to MR-Linac from Elekta, this is right now only available because the other vendor is almost done. So they have a 1.5 Tesla MRI. The energy of the beam is 7 MB. The system is completely different from the conventional, because in a conventional you have the source to axis distance 100, but here it's 143.5 centimeters because you have the magnet sitting in the center and then the accelerator going around the patient. And only technique available is step and shoot, and the dose rate is 425 MU per minute, although the guide can create such a very high dose rate of 3000 MU per minute, but because of the distance and the cryostat attenuating the beam, it comes down to 425, and the revolution speed is quite good, 6 revolutions per minute, and the release speed is also quite good. Compared to the conventional MRI and this MRI, the only difference I would say is that is the slew rate, because the peak slew rate is half of what you can see in a conventional MRI. That could be one of the reasons where you cannot do any spectroscopic measurements with this, or you cannot do any kind of a cardiac cardiac MRI with this machine. Otherwise, it's as good as like a conventional MRI. We can do a T1, T2, DWA, FAR, and CD imaging. Spectroscopic is slightly, right now, not possible. And they have a very nice design, split gantry design, split magnet design. So you have the magnet being split into 2 pieces in the sense and you have a slot there in between. So through this area, the radiation is delivered so that the radiation does not hit the gradient coils. Because if it's going to hit the gradient coils, it's going to have a problem issue with that. So problem with the imaging. So it's very well designed in such a manner that the radiation is delivered in the center this area so that the gradient coils are not being irradiated, but the magnetic field homogeneity is maintained in the sense like without having any kind of a, because of this break, it does not have any kind of inhomogeneity in the center. Coming to some kind of what difference it with compared to the conventional bunkers, the energy of the beam is 7 MV, so you will have a similar to a 6 MV bunker, but only thing is that like you have to take the MRI inside, and the MRI is a single piece which is almost 2.5 meters in diameter, so it cannot be taken through the maze, so you have to construct in such a manner that you keep this opening there. Once you take the MRI in, and then you can fill it, or you can take it from the top, put a slot, and then take the MRI in, and then you fill it up. So either way you can do, it's little different than the conventional way of doing it. Not only that, as I said, the MRI has to be shielded from the LINAC. So there are 3 rooms here. You have the machine room, bunker, where the treatment room where the patient is there. The patient is inside the Faraday gauge, but the machine is outside the Faraday gauge, because the Faraday gauge protects the machine from the RF signals. So whatever the RF signals are in the machine room will never come to the LINAC inside the patient room, whereas both are together and they work together. And coming to the, because it's a big machine with, you need to have a height at least 3.5 meters from the floor, and you need to have 1 meter pit. So that has to be really designed before you make a bunker for that. Not only that, here conventionally you can keep the isotope anywhere in the room, but here it's not like that, because the whole design goes with the corner of the room. From the corner of the room, it's a finite distance. This distance is maintained everywhere. You go to US, you go to India, the machine looks similar because they have this stringent, this one, because anything they change the linear accelerator isocenter position, a lot of things will change. So it will affect the image quality, it will affect the mission performance, so they cannot do that, so they have to stick on to that. So wherever you go in the world, the MR-LINAC looks similar. Coming to the construction, as I said, you have the slot where the LINAC is present here, and the MRI is, has a gap through which the beam is delivered. The distance from the source to axis is 143.5 centimeters. So it's quite far away, and that's one of the reasons where the dose rate is quite less. And the design is such a manner that because you have the magnet, MRI LINAC rotate around the magnet, so you're going to create a lot of eddy currents and create a lot of inhomogeneity in your magnet. So what they did, they had a lot of shimming coils, which can really, like, if you have the unwanted harmonic field is like this, then if you add your shimming coils exactly opposite to the harmonic field, automatically your inhomogeneity gets homogeneous. So this is done very nicely in the machine so that you don't have to worry about the magnetic inhomogeneity. And this is a nice one where, as I said in the beginning, the magnetic field here is almost 50,000 Gauss, and the accelerator is here close by, and it gets reduced to 5 Gauss. So the shielding materials, the high shielding magnetic shielding materials are able to really bend down the this magnetic field to make sure that the accelerator is completely saved from this one. That's why you see this such a big one. Inside this is the accelerating guide, which is responsible for the X-ray generation. And the guide is also so special because it's not like a conventional guide. It's in a very high vacuum with the much higher vacuum than the conventional waveguide. So that's the reason, like, any problem in the gun, any problem in the target, you have to change the entire thing. You cannot bring down to the atmospheric pressure and do it like what we do in a conventional accelerator. You cannot do that. You have to change the entire not a mission, entire waveguide along with the target and gun. So problem, but still the design is nice because it has to be shielded from the magnetic field. And the technology is little different because in a conventional accelerator, the gantry goes to 180 and comes back. It never goes full round. But here they have changed a little different because they made a slip ring technology, like what you have a CT scan. It continuously can rotate. So the power and interlocks are transmitted through slip ring technology, and also the data are transferred to the high-speed Wi-Fi. So machine can go round and round, no problem, because there is no wires which are getting connected, because the transfer of power and interlocks communication is through slip ring technology. And also some nice design change where the big modular cabinets you see in a conventional accelerators have been remodified, and you have a solid state pulse forming network. So it's quite small and handy, and it can be really worked out. And this is the distance between the pulsar modulator and the waveguide. So very short distance, and you can generate the X-rays. And again, how do you cool the machine? Because you have no wires, no tubes connecting to the machine. So what they have done is that like, they have attached the fan to the gantry, and which transmits all the heat into the atmosphere of the room. And there is a heat exchanger which absorbs this heat and cools the entire room. So through the air cooling, the system is done, like literally like a Wi-Fi cooling. So you have the chiller coming from, chiller water comes to only to the chiller, only to this cooler chiller, water comes only to this chiller and never goes to the machine. So machine is cooled with the help of these fans here. So nice design. But having said that, they have a lot of restrictions, like the collimator cannot rotate, because this is the reason. You have the magnet here and you have the collimator here. No way you can rotate, because you're going to smash everything. So the collimator is always fixed at 90, and you're going to modulate only in a chronocoordinate direction, not like video direction in the normal visions. Again, some areas where we see different is that like the quench pipe, which is needed, because in case of emergency, you have to let out the helium gas. So you cannot keep it in the room, so it can occupy all the oxygen in the room, so it can be dangerous. So you have to have a separate tube, and this tube goes through your bunker. So straight hole on the bunker, and it goes out and goes into the atmosphere. So that's again a different design you have to remodify when you do a bunker design. And also the cold gun deck usually happens in the center of the MRI, has been shifted to the front end, because the center of the MRI we have the LINAC rotating. So compared to the diagnostic MRI, you see the cold head coming in the front, and that's get connected to the quench pipe. Okay, what are the effects of MRI and a LINAC? LINAC on the MRI, a nice study which clearly shows that with this machine rotating around the patient, the peak-to-peak change in the homogeneity of the magnet is much lesser because of the proper shimming and active and passive shimming coils along with that. MLC is again agility MLC, what you have in Versa HD, and it has got a beam attenuator. So it's nice because it will only 0.5% of the primary comes out of the machine. So the shielding wise, the safety wise, it's quite good, and you don't have to worry about the bunker thickness. This is how we started, and we have the gantry ring attached to that. Then you have the MRI coming in, getting attached to the machine, and the RF gauge done, and the machine is ready for the commissioning. Coming to the effect of magnetic field on the X-rays, on the LINAC treatments, the penumbra increases by 1 mm, the buildup decreases by 4 to 5 mm, and then the field is shifted, as I said, to a 0.7 mm, but the field width remains same, so that has to be there. But if you can model it, you can definitely do a proper calculation. But there are some other issues, like absolute dosimetry is totally different, because you have another factor, KB, because you have the magnetic field there, always present there. So you have to account for that, and you have to be careful. You put the chamber in the perpendicular or parallel direction. Accordingly, you have to apply the correction factors. So when we did the all the work, we were really scared, like, are we treating the right one or not? So we tried to do an inter-comparison with MD Anderson. We sent the TLD capsules and measured, and we could really see that what we intended to deliver was 299, and we got the dose as 299. So, okay, we are not that far away, although it is matching perfectly, but still there are so many uncertainties on that. So still we are definitely good in that. And we did again other studies like how good is my MRI. Geometrical accuracy has to be very good. So this is again a typical geometrical without correction, software correction. If you measure, if you image a MRI, a phantom, it will be like this. So with the 3D correction, it definitely gets better. And this is our results. And we could really see that in a 30 centimeters diameter, the values are less than 1 mm, but when you go to 50 centimeters diameter, it goes up to 2 mm variation. So whenever you have a target of extremely close to the bore, you should remember that there is a 2 mm off center, is a mismatch can happen at the periphery of the bore. Coming to the isocenter, MB isocenter is very good because it's a ring gantry. So the diameter is 0.29, so definitely very good in that aspect. But there is an MRI also there. MRI has its own isocenter, so you have to have both the things matched together. So it is not like both the isocenters are matching like what you do in a conventional KVC, VCT. Here it is little far away. There is a difference between the MR isocenter and MB isocenter. But only thing is that you have to make sure that these isocenter value remains ever in the same way, so that the system automatically corrects your images. Whenever it takes the MRI images, it applies these correction so that you don't have to worry about during the delivery. Of course, you have to compare all your data, as Dr. Ganesh said very nicely, that you have to compare the data because you cannot think that what you are doing is right. So we just shared our data with and tried to compare with the global institutes, and you could really see that we are not very far away from that, and almost we are close to what the other people are doing in terms of output factors, profiles, PDDs, and energies. We did end-to-end QA with the nice Series Phantom, and we could really see that the positional accuracy coming to 1 mm, and dose accuracy, we have chambers in that, so measured the dose accuracy was good. This is again, we did so many tests on the MRI to see that MRI is good as per the task group protocols. There are two workflows, ATP and ATS. I will not go much into that because there is some separate presentation on that. So as I said, like this machine does not have the couched movement. So as this does not have the couched movement, you have to move the beam. The moment you move the beam, the penetration of the beam is going to be a little different if there is a difference in the tissue density. So you have to recalculate. So, or you can do one thing, you can recalculate. If the dose is not proper, then you can do change the mu per segment, and then you can adapt the shape and adapt to the position. Both can be done. So that's one way of doing it. Otherwise, that like you can recontour, re-optimize, replan, and do it. So complete doing it. Some of the clinical things we have done is we have treated almost 453 patients in the last 1 year, 8 months. Almost 12 to 14 fractions patients per day. Although we went up to 20 and came back, we could not do it. It was too torture for the human resources, was too much struggling with so many patients doing that on a single day. We have adaptive position of 54% and adaptive shape. The adaptive position is more because we do a lot of brain treatments, private hospital pressure. And what advantage you get with the brain? This is a typical 5 fraction treatment. We planned nicely, and then when we tried to deliver the treatment, we could see that the brainstem dose was little higher than what it is supposed to be there. So we recalculated and replanned. So this advantage you have because you are able to see the tumor so well and the boundaries so well, so you can adjust the dose to the critical structures, and then on the fly you can plan and then treat. This is again a typical SRS case. We did 1 or 2 patients AVM, which you will not be able to see in the CT or a CBCT, where we could see nicely the nidus and then deliver it. But we make sure that, of course, we don't have a non-coplanar image, non-coplanar treatment, but we make sure that our V10 and V12 was less than what you do in a conventional one. Again, head and neck, of course, very difficult to do in the sense like you have too many structures to plan, check, and all those things. But it's worth doing it because sometimes if your dose variations are more, and you do a simple re-optimization, and then you get everything in picture, like especially when neck position is there and the spine dose is going higher or the parotid dose is coming higher, this gives an opportunity to adapt the plan and deliver the dose. Of course, you have to be careful because there is a possibility that you can deliver a high dose to the tissue air interface, so you have to always keep a watch on that, otherwise you have to be careful. Even though the models, you have to be really careful. This is again our own patient, head and neck patient, starting of the treatment, and you can see week 1, week 2, week 5, week 4, and week 6, a good reduction, and then this gives nice this one. This again, we just added that very few breast patients we did, but one thing we found is that most of the time the breast is not moving, the heart is coming more actually. So we take a snapshot in CT and then treat the patient, but here you can do a real-time imaging. So this is when the beam is on, you can do a real-time imaging. So it gives really nice confidence, more things that then we replan and then we recontour we give the margin to the cardiac and then replan and then treated the patient. So that's nice because you have to have a real time. And also the clinicians are quite happy because when you're delivering the beam, what's happening. So you can see that. This is again a esophagus case, comparison between CT and MRI. The PTV volumes are quite less, so that makes a lot of difference in the of course, the toxicity can be lesser. So this again, you can see the opening of esophagus during the treatment and the response during the treatment. That's quite good. And again, a spine SBRT, you can do a focal boost because you can see it much better. In CT also you can see, but here you can see much better. Of course, it has got a very good advantage in the stomach, abdominal area, liver SBRT and pancreas SBRT. Every day you have to replan. That's like no way you can treat. We have never done ATP on that. It's always ATS because it keeps on moving, so many structures coming in, so you have to do a complete replan and treat. This is one of the results of the patient whom we have treated, like pre-treatment and post-treatment response. Again, pancreas, I already told you that the same similar. And this is again a typical case where the patient has only one kidney and there is a metastatic tumor there. So we did this patient almost 1.5 years back. We treated with SBRT, and we could really see he came for follow-up and there's nothing there. So and the kidney is functioning fine. So that gives a lot of confidence with this system because we could see really nicely and treat. Prostate, of course, morning we had discussion, so it's a lot of applications, but only thing is that there are something which we can do which is not possible in CT, I feel, in the sense you can do a urethral sparring, not very much, to at least not have the hot spot in the urethral area, you can avoid hot spots in that, there are nice literature. Even we also did the similar, we try to keep the low, not the low dose, 95% in that area, not 104 or 105 in that area, and avoid dose to that urethra. And not only that, you can try to do a sub-volume boosting because in prostate tumor, so you can see the tumor very clearly. So it just opens the door. Of course, it's up to the clinician to take a call, but still the system gives you the opportunity and opens the window for you to boost that area with little higher dose. Clinical advantage, I don't know, but still this gives the opportunity for you to do that, and it clearly, in this case, we could really do that. Again, the advantage of having a real time is that when you are treating the patient and suddenly there is a gas, the whole prostate goes out. So this can be monitored, of course. You can pass the beam and treat and deliver. So if you have a gating, then you can really do a much better job. This is again a rectum case where there is a drastic reduction in the tumor, and we can definitely worth doing a replanning and adaptive planning. Again, in the morning, we had discussion on the cervix. This is a big tumor, 10, 12 centimeters, started melting like anything. At the 25th fraction, it's almost very less. And then once of course, reducing the margin, I don't know. But still, we are using 5 to 8 mm margin for the cervix. Initially, we started 5, but it is not working out, so we went to 8, and then we are working with that. But not many patients on cervix. Coming to the patient complaints, we treated 6-year-old to 78-year-olds man. Indians are very good. They are not complaining. Nobody has complained about the claustrophobic sound or something, because we get more sound in the traffic than in the machine room. So they are able to complain, and nobody has stopped the treatment in between. And coming to the QA, it's quite good because we do every patient treatment QA and then deliver, because it's a new machine, we don't know. C-arm linacs are well established, so we have to do it. So every day in the evening or night, we do a QA of that next day's patient and then make sure that everything is fine and treat. But this is again a nice example where we started treatment and then lung treatment, and we could see that suddenly the tumor is going out. So in this case, we have no option. You have to just press the beam off. We have no gating that time. So now we have gating has come. So you can do a breath hold, you can do a free breathing, you can do a exceptional gating, or you can do a in brief inhalation. So it's nice. The system is do the job for you. You don't have to do anything. The system, you can create an envelope. Even the prostate tumors also, you can create an envelope. If the tumor goes beyond that, immediately the system stops. So that's nice. That's a very nice thing the company has done. And now they are working on tracking, like if they can track it and then deliver the beam, because the MLCs are there, so we can do with us. And this is again, we have not reached, but this could open the door for biology guided. So you can do a response guided treatment by doing a diffusion weighted imaging and try to take the apparent diffusion coefficient and take the values, which can be a predictive factor in some sites where you can use it and then try to boost that area. And even in this case, they have shown for a head and neck case, ADC can be a biomarker or can give us some prognostic factor for these patients where you can do a B500, B1000 values and then get ADC and do the treatment. Of course, cascaded radiotherapy we have discussed in the morning, so I don't want to do that. But still, there are so many things as to have do, especially in terms of motion monitoring. They have to work on it. Response guided adaptive radiotherapy is still not there, and VMAT is long way to go, because, and I think VMAT will not add much benefit because the MSCs are in a cranial-caudal direction, and also not possible to move as speed as like what you can do in a conventional accelerator. Thank you.
Sir, I want to ask few basic question. Whether there are MR compatible QA devices separately for
Yes.
this?
Yeah, right from the chambers, it has to be MR compatible.
Okay.
And but there are some devices which are MR conditional, not MR compatible. Like suppose if you take an ARC check we use for patient-specific QA, but we cannot do an MRI for an ARC check. If I do an MRI for an ARC check, that's the end of ARC check.
Yes.
So because the RF signals will heat up the chamber, the cables, and it will burn the cables. So automatically it will stop. So there you have to be careful in whether it is MR conditional or MR compatible.
Okay. And in addition to our routine daily QA check, what are the additional tests you have to do?
Yes. For MRI, it's a separate PAQT. We do that. We do everyday morning PAQT checks to check the image parameters. And for the LINAC, it's similar to what we do with like basic flatness, symmetry, energy, and output, and feed size.
And what is the use of planning CT in case of patient alignment and all?
Yes, planning CT is a must, because to be honest, in CBCT, you have the advantage in the morning we had seen, CBCT can get your HU values as close to the diagnostic CT, but here it's MRI, there is no electron density information. So to get the electron density information, I have to have a diagnostic CT done. Without diagnostic CT, we cannot go ahead with that.
No.
Till they have not come up with the synthetic CT of generating synthetic CT from the MRI, it's there. But if you have a diagnostic CT, it makes sense.
So for day-to-day patient alignment,
day-to-day treatments,
how you are using that?
It is a bulk density assignment. So it takes from the diagnostic CT and it just a bulk density assignment and treat the patient.
Okay, okay. Thank you, sir.
So just a clarification. So your workflow is that you will do a planning CT scan.
Yes.
And you will also do a planning MRI?
Yes, planning MRI is there. We'll do an Unity MRI.
Unity
MRI, like
MRI.
in the mission, we put the patient, depending on what sequence the clinician would like to have, T1 or T2. Because the T1 contrast you want, then you can do it here, but it takes going to take time.
And there is an automatic, fusion software. How does it work?
Now, the table is flat. You
Right.
get very good match. You don't have to worry on that aspect actually, because the same immobilization device which you use in the CT scan will be used in the Unity.
Right. And then you load your CT and the Unity MR into your planning system?
Yes. And
you-
the clinician, when he does the contouring, he will have both together. He'll have a diagnostic CT or diagnostic MRI, and PET of course will be there. So he can choose whichever he want to do that.
Right.
And he can, in the online also, he has the opportunity to see the PET, MRI, everything.
Okay.
Suddenly you have a doubt, you can see that.
This electron return effect which you mentioned, is it only for the electrons that are moving from a dense medium to a rare medium, or even within the dense medium itself the electron return effect will be seen?
Yes, sir. It will be there even within this one, but it will be more pronounced when it moves from the high density to low density. So definitely the system Monte Carlo models that, because the mission, the moment you go for a planning for a Unity, it will ask you that 1.5 Tesla will be applied. You cannot get out of that. Then only with that it does model that. And also there is one more thing I want to tell you, that there is something called electron streaming effect. Because you have the high energy photons hitting the collimator or the MLCs, there are a lot of electrons coming in the air, which adds to your surface dose usually. But these surface dose gets reduced here in this machine, but it's been pulled out into the mission. So when it pulls down, especially when we treat esophagus, we keep the bolus on the chin. Because what happens is that if you don't put that, these electron streaming will go and deliver the dose to the chin. And it's an unnecessary dose to the patient who was treating for a esophagus, getting a chin dose, but not very high dose. It will be around 50 centigrade for entire 30 fractions. But even the 50 centigrade is not acceptable at all. So we keep a bolus on the patient here so that it doesn't hear. Whenever we treat something on the chest, we keep over here.
So will the Monte Carlo will be able to...
Monte Carlo will tell that, but you have to protect it.
No, but even otherwise the dose calculation, Monte Carlo, does it take into account
Yes.
all these effects?
All these
perfectly?
effects, it's been taken into account. So definitely.
Thank you.
Can I ask you a question, Sai? So in your previous talk on CT based, you mentioned already very briefly that with this new hypersite by Varian on an ethos, you have really good quality, and I can confirm that we have these ethos systems, and you really approach diagnostic CT scan quality. So it's even to an extent that we do a lot of pelvic adaptive there, and so this is completely run by RTTs. So RTTs adjust target volumes, and of course specially trained RTTs. And so my question to you is, I mean, no doubt that you have a better soft tissue contrast in MR, right? And there is no doubt about that. But we do not have to do diagnostics. We have to treat, right? We have already a target.
Sure.
And so if you don't see all parts of the target, if you see enough parts of the target, you can move it where you want. And yeah. So there is all. So in my view, but you can respond to that. I think for many cases, it really has to be seen what you can gain with MR guided adaptive. And I mean, there is certainly cases where you can, I believe also. And but in all these cases, then there is also this cost effectiveness, right? And yeah, maybe you can respond on this.
Yeah, I fully agree with you. You don't have to have a 100 crore machine to do this work, because already you have systems which are doing very good job, and with hypersite adding and then EVO coming up, I think you can do almost 70 to 80% of the job what you do in MR-Linac in this mission. Especially the places where you can really get benefit out is pancreas, where not diagnostic CT itself has some issues. So that case, okay, we can justify it, and prostate, seminal vesicle somewhere you can say that. Otherwise, or the head and neck and brain and all, I think, unless otherwise MR comes up with some kind of a diffusion weighted imaging advantage, then it makes sense.
Yeah, but that, I mean, that is really
that is
at
long
the beginning.
It's
long
road.
Yeah.
Sir, what do you do if image artifacts is there during planning on MR-Linac?
In MR-Linac?
Yeah.
Okay, that's right. See, usually we don't have like what you get with the CT. The MR-Linac, you don't get that kind of artifact actually. But of course you get that the moment we see, that's why whenever we take the patient in a planning CT, we do an MRI in our machine. If we are getting an artifact and it's going to be there in the target area, we say that he is not for MR-Linac. We just send him out and take in the other conventional Linac and treat him.
Okay. How do you measure cross-plane beam profile? Cross-plane beam profile.
Beam
how
profile.
do you measure?
Okay, that's a nice question. Because this gantry, you have very confined area, so you have to have a gantry 90 and do all the measurements. So even the commissioning also we do with the gantry 90 and all the measurements.
Thank you, sir.
One more question. The surface imaging is not that much good in MRI images.
Yes.
So in head and neck case, how you identify the shrinkages or the surface change?
The amount of changes which we normally see that can be seen very nicely. The only thing is that the skin is not very well visualized actually. Yes. But when you have an RFIT, so you could really get some idea about that.
Sir, it is required to use any specific MR coil with the immobilization devices at the time of image acquisition?
You're talking MR coils?
MR coils.
Of course, you have an anterior coil and posterior coil. Posterior coil is always inbuilt in the couch, so you don't have to do that. But you have an anterior bridge, so always you have to use the anterior coil because you're going to do an image, you're going to do a real-time MR imaging, so you have to have this coil. But these coils are already modeled in the planning system, so you don't have to worry about the dose calculation and the penetration and of this particular one. Only thing is make sure that the electronics of the coil is not irradiated during the treatment. Otherwise, the coil is quite. It is possible to use the coil when the beam is on.
One more question, sir. At the time of patient image verification, if the translation or rotational shift if applied, you say the table is not moving, then how can I apply the rotational translation shift?
Yes, okay. So here, because the thing is that like there are too much are there, the contours are there. Because the moment contours change, we can replan it. We are doing a planning again here, so you don't have to worry on that aspect.
Okay, thank you, sir.
So when you do an adapt to shape, on an average, you know, what is the on-couch time that a patient
Yes.
has? About an hour? Or
40 minutes.
40
minutes. It was an hour, but once you start doing more and more cases, because the team is trained, so it comes around 40 minutes. But if you have a brain case, 20 minutes, you can, in and out, you can finish. But if it's going to be a head and neck, 30 minutes. And another caution of word is that like the beam on time is more here, because you're doing a step and shoot. Your dose rate is less, so the beam on time is more. That's also going to contribute to your total going in and going out. So 40 minutes, cervix 40 minutes.
So that's why on an average you're treating about 10 to 14 patients in a day, because a lot of, if 50% is adapt to shape.
Yes,
then
you're out actually, and the contouring time also takes time because it's not easy.
Thank you.
Thank you. So you mentioned this. I think it was in the last slide. It was a type of gating that you can do. And what I've noticed is, what I've read is that many of MR-Linac users really still use, if there's respiratory motion, they use
IT.
Kind of corset, I don't know how you call it in English, so a pressure belt or something to reduce motion. So why is that? Is that because it's longer?
Yes, because the treatment time is longer.
Yeah.
So so what normally we do is that we don't put a belt, we make a very tight mask. So that somehow compensate that.
Okay.
I think the compression belt we use to reduce the PTV, because otherwise if we incorporate the whole motion, ITV will be bigger and then the volume of normal tissue radiated. So it's just to reduce the total field.
Right.
So,
Thank you. Thank you, Dr. Singh. Yeah. We'll have Mirit give the next.
Thank you, sir. Now our next session is on MR-Linac based adaptive radiotherapy implementation by Dr. Mary Delhi. Welcome, ma'am.
Okay, so we had a really great introduction to the tech of the MR-Linac and the differences between MR-guided adaptive radiotherapy and CT-based. And there are a lot more challenges with MR-guided. It makes it a lot more interesting, a lot more exciting, but there's a lot more things that we need to think about. So hopefully, after this talk, we will have answered some of your questions. So I'm just going to refresh us on the rationale for adaptive radiotherapy because, obviously, we've discussed it a lot. But I think I need to just reiterate it because it's more the last section that we need to think about. We need to think about what's happening with what adaptation that we need to do based on each site, and because it will influence what imaging we acquire, the rate of change that we anticipate in that site, and therefore that will influence our workflow selection on the treatment unit. So we do need to kind of take it back to first principles and think about these things. And also, of course, the workflow selection will then impact our resource allocation, so i.e. all our members of staff. So, you know, we've seen this before, but again, I will just remind us about the different timescales of changes that we will see on treatment because, again, that will impact the type of adaptation that we will do. So we see very quick motion with, for example, cardiac motion, motion over the order of minutes with regards to like peristalsis, bladder filling, and respiratory baseline drift. And then obviously the longer and slower changes with regards to weight loss or tumor growth or shrinkage. So just to refresh on general adaptive radiotherapy strategies, we have 4 kind of key ones. The first one is reactive, so that's kind of typically what we would do on a conventional Linac. We will see something has happened with the tumor or the patient, something has changed systematically, we need to replan. So that is kind of a very commonly employed strategy for adaptive radiotherapy. And then kind of using that information, we know that we always have to adapt head and neck patients in week 3, for example. Perhaps we could schedule in some adaptation. So schedule in a rescan at this certain time point and proceed with it that way. And that kind of helps with resource allocation because you kind of know, okay, this patient will have a replan at this stage. And it just makes it a little bit easier for everyone and less panicked because you need to make sure that the replan process is quick enough, i.e., the scanning, planning, and QA of the plan is quick enough for you to be able to actually see enough fractions to have the benefit of this new plan. You don't want the plan to take 7 days and then you only treat 2 fractions on this nice new plan. It would kind of defeat the purpose. So proactive strategies predict likely changes. So for example, in gynae cancers, we see a library of plans or a plan of the day approach where we kind of know that, with bladder filling changes, there are some kind of likely changes that we will see. So we can kind of predict those and include them in the adaptation and, deliver a plan of the day based on that daily anatomy. And then there's real time, and that's kind of broken into 2 time points. So this is a new plan that's generated online. So the more common version is what I will talk about in more detail shortly. So that's, you see the patient, you generate a new plan for the day and you deliver it. But also increasingly there's an investigation into intrafraction real-time adaptation. So that is continuously adapting the plan, very slightly re-optimizing it based on very fast changes during the treatment, for example, respiration pattern changes. So we've heard a lot about the kind of benefit of MRI over CT, and I think, we can discuss afterwards about, which patients should maybe be triaged for the MR-Linac versus a CBCT approach. But of course, we know that, MRI has good soft tissue contrast. But that's kind of not just it. It's not necessarily going to be better than CT or CBCT in every case. So it's definitely important to look at this on a case-by-case basis. But on the area that I focus on clinically, in the liver, for example, it's very useful for us to be able to see the exact tumor extent, but also changes in it. Also, we've seen in the previous talk about functional information, so that's kind of where MRI really does have a little bit more of an edge, and this is more of an experimental approach at the moment, but there are multiple different ways that we can image, because MRI isn't an image. We take a CT as a CT. You have your different parameters, but it's a CT. MRI, there are many, many different sequences that we can acquire. So some of the different techniques that we have are diffusion-weighted MRI, which shows us the water molecule diffusion within a region and basically shows us kind of the cellularity. Dynamic contrast enhanced shows us the tumor microvascular changes during treatment. And we can also do oxygen-enhanced MRI and looking at areas of hypoxia with potential to boost those regions in the future. So there's multiple different ways that we can look at our targets with MRI. And just to remember that MRI is not one, you don't just take an MRI, you need to know all the information because of this, all these different sequences and techniques that we can use. So yeah, we've had an introduction to the different MR-Linac types. There are 4 commercially available MR-Linac types. But I'm going to be focusing a little bit more on the Electa Unity today because that's the one that we have in our department. So speaking about our department, so at the Christie Hospital in Manchester in the UK, we implemented our MR-Linac, and we actually celebrated the 5-year birthday or anniversary this summer. And you can kind of see how we've stepwise increased our kind of processes on the MR-Linac as we've gone through. So in 2019, we treated our first patient. And then in 2020, we started some experimental work on using medical gas, implementing medical gases for imaging of the functional side that I just explained. And then we expanded a year later to treat some head and neck cases, lung and cervical cancer. And then in 2022, we started moving towards some kind of a little bit more trickier sites, including the bladder and pancreatic cancer, but SABR only for the pancreatic cancer. And then in 2023, we started RTT-led pancreas online organ at risk recontouring, so kind of helping with the workflow, and I'll be talking a little bit more about that shortly. And then this year we expanded to treat liver cancer. So we start with primary liver cancer, HCC, and it's SABR as well. So it's just to show you that when you get when you get an MR-Linac, you don't have to start with everything that's very, very intense and very, very difficult immediately. It's okay to start with something that's more straightforward. We started with a lot of prostates to kind of get our competency up and get comfortable using the system. And we, would use our gold standard current treatment that we would use on a conventional C-arm Linac. So it's just to show that once you get this new toy, you don't necessarily have to go straight to gating and smaller margins and everything. It's more important to do it in a stepwise approach, because that just means that everyone is really comfortable with the process. I just wanted to highlight some of the cool work that has been done in our department. We actually were the kind of first to do oxygen-enhanced MRI on the MR-Linac system in patients with head and neck cancer. So if you're interested in that, I definitely recommend looking at this paper. So with regards to MR-guided radiotherapy, and particularly adaptive radiotherapy, there are a lot of different things that we need to think about. We've heard about the Linac hardware, but there's also considerations with regards to MR safety, with regards to the dosimetry, as we've just heard previously, and then immobilizing and positioning the patients, and the kind of slightly different factors that we need to take into account for MR-guided radiotherapy. The imaging is different, as I'll explain, and obviously that will then impact our workflows. Also, it's a lot more of an MDT approach, and it is definitely currently at our department very MDT focused, so we would have all members of the radiotherapy group, our oncologists, our physicists, and our RTTs working together. And then there's just that decision making, and I think this kind of came up earlier about now we're potentially seeing more and maybe seeing things that we might not have seen previously. So kind of what do we action or what do we not action? So there's a little bit more of decision making that needs to be taken into account with MR-guided adaptive radiotherapy. I'm going to be focusing a little bit more on these ones because obviously we've heard very nicely in the talk previously about the other factors. So anyone here using MR, like diagnostic MR scanner in your pathway? Anyone been in the room or been really involved in it, in scanning an MR? Few people, yeah. So there's a few more things that we need to think about, right? Going into a CT scanner room, you can just walk in. If you're an RTT, you probably have some metal rulers in your pockets. I'm sure that's universal. You got your badges, your phone, your Apple Watches, There are a lot more different things that we need to take into account with regards to MR safety. So as mentioned in the previous talk, we use an anterior coil to be able to generate our images. So you can see this positioned over a head and neck patient. So the head and neck patient is wearing an ORFIT shell, and then they have a neck coil that's can you see that? Yeah, a neck coil that's positioned around kind of the top of their neck there. And then we have the anterior coil there that is kind of slides up and down the couch, and we have to fit it on. Also note that we have headphones because obviously with MR, a lot of acoustic noise is generated, and that can potentially damage hearing in the long term. So what we use is little foam earplugs inside the ears, and then these big ear defender headphones over that. So with MR, we have two things to think about, just to make things nice and simple for everyone. We have not just the radiation safety, which we would have on a standard CBCT-based Linac, but we also have the magnetic field. And on an MR scanner, the static magnetic field is always on, so it is always functioning. So it's important to be able to kind of manage the safety with regards to that. And we can also get RF burns on the patient. So anywhere that skin is touching, it's important to kind of separate that. We put either like a little bit of a pillowcase or some, just some fabric between them, making sure that we're not kind of creating a circuit where we can kind of generate some skin burns. So it's important to think about things like that when we're positioning our patients, because in our department, our pelvis patients, we would typically have hands on chest like that. But obviously in the MR, we can't do that. So we get them to hold a little handle so that we're not kind of creating a closed loop to be generating burns. Same with legs touching, so tops of the thighs, so we make sure that that's avoided. So we kind of have a few extra things to think about and considerations and things that we need to train all our staff on before we even get started with all the fancy stuff. There's a lot of resources available online with regards to preventing MRI burns and MRI safety, but as I mentioned, so one of the things is here having patients change out of street clothes. We get all our patients to change into kind of hospital scrubs, so that avoids any issues with coins in pockets or anything that might be hidden that can become a projectile. So that can actually be pulled by the static magnetic field out of the patient's pocket and towards the machine, and that could cause damage to the machine, but it could also cause injury to people within the room. So definitely making sure that you're kind of keeping your wires, making sure they're not coiled, making sure we're not kind of creating any circuits. And also kind of top one here, looking at our objects, and I'll go through that a little bit more shortly. But there's plenty of resources available, but it's really important before you even start with anything else, because you can really injure a patient or cause quite a lot of damage to your machine, and you definitely don't want to be doing that. Your boss will be not happy with you. So with regards to patient positioning and immobilization, we do pretty much the same as what we would do on a CBCT-based LINAC, but with these few considerations with regards to MR safety. The first one is our immobilization devices. So when we purchased our MR LINAC, we also had to purchase MR safe immobilization devices, and we heard about MR safe and MR conditional earlier. And basically, these are the three stickers that are typically used universally to identify which products are able to be taken in the room. And they should be all clearly labeled, even ankle stocks, absolutely everything should be tested and then labeled accordingly, so that there's no doubt and there's no, when you're running behind and you're running late treating patients, that there's no confusion as to which one you can take in. Because of course, a standard foot stock may look very similar to an MR safe one, so it could accidentally be taken into the room. And then MR conditional, just to note the one in the middle, so obviously we know green is good, red is bad. MR conditional in the middle is basically that it is fine to take in the room and image at specific settings or under specific conditions. So when something is MR conditional, we should then also know what the conditions are for that item, that we're not exceeding any of those conditions and then therefore making it MR unsafe. We need a reproducible setup, of course. That's radiotherapy. That's what we need for everything. But with the MR LINAC, we need to think about things like arm position, as I mentioned, making sure that hands aren't touching, and also having the headphones, trying to get the headphones to fit on the patient when there's a vac bag in the way or over an orphet shell can be challenging, but it's really important to make sure that that is done properly. So what we do to kind of test that is when we are on the planning or simulation scanning day, we will scan the patients with a kind of mock set of headphones, and that will be able to kind of see that the vac bag has been created, that it all fits okay. So that's something that we recommend doing. Obviously, we can't use these exact headphones because they actually attach into the couch so that the patient can hear us as well. So we just use a kind of standard set of ear defenders during the simulation scanning. And then, of course, we need to think about motion management. So we use, for our abdominal patients, we use abdominal compression belts, a belt that inflates. Again, it has to be an MR safe or MR conditional device that we use. But we use that for these patients to limit the kind of overall total excursion or movement of the target, and also potentially reduce some of the variability with positioning internally with regards to breathing. So we use abdominal compression currently. There is the possibility of doing breath hold treatments. We do not have that capability currently in our department because it requires both software and hardware upgrades. But this is something that is definitely something for the future and something where we'll see some great benefit on the MR LINAC. So as I mentioned, when we're acquiring MRIs, there's various different sequences that we can take. I'm sure you've all have been acquainted with a T1 and a T2, for example. And on the MR LINAC, it's no different. We have a wide range of sequences available, and we can often kind of create and tweak our own sequences in addition to the ones that elect to give us as a vendor-approved sequence. So you can see a selection here, and they vary in time. As we saw earlier, there's a 2-minute prostate or pelvis scan, and that's really nice. But for certain sites and certain sequences, depending on what you use, the acquisition can take longer. Typically, at the simulation day, we will acquire a planning CT in the treatment position, and then bring the patient straight over to the MR-Linac and acquire, in the same position, a number of sequences that are kind of appropriate for that site. And then the clinician will select the most ideal one for use to go ahead for delineation based on what they need to see and what we need to do. But it's important to select the sequence that's appropriate for the task, and it's important to try and get the best one kind of to achieve all tasks. So sometimes using a sequence for IGRT, so to verify position every day, if we're using a sequence that is excellent for seeing the target, but seeing the OARs is very challenging, that may not be the best sequence to use for IGRT, depending on what the indication is. So trying to work out what is the right sequence, and the best way to do this is by imaging studies. So when we opened our MR-Linac, we also opened a number of imaging studies, and I think I'll talk about them shortly. But yeah, being able to kind of identify, based on your scanner and your department, what the best sequence is for each task. But yeah, it's important to consider the acquisition time, because you're seeing the longest here is 6 minutes. And that doesn't sound too bad, but 6 minutes on top of everything else that we need to do can make things very, very long. So consider that acquisition time and make sure it's appropriate for what we're doing. Also looking at the field of view, if we reduce the field of view, obviously that can reduce our image acquisition time, but then it can reduce the amount of information that we're getting. So it's important to kind of consider all of these things. And also, I'll talk about the workflows shortly. But selecting the imaging and selecting the stage at which you're going to acquire it during the workflow is important. And you can see here a range of images that we have for one single patient. We've got the planning CT here, and then a number of different MR sequences, as well as a diffusion weighted just for fun. But you can see the difference between them. Also on the top here, we have a free breathing T2 image and a abdominal compression image. And I think you can appreciate that the abdominal compression one is, a little bit crisper and a little bit clearer. So that's showing why we use it for our abdominal patients. So I think artifacts were brought up earlier. I'm not going to go into them too much. It's not my area of expertise, but just to discuss them very slightly, it's something that we need to think about, and they work very slightly differently in MRI. But there's a wide range of artifacts that we can see in MRI. And again, it's important to test this within your own process and work out what it is that you need to do to reduce them or potentially tweak your sequences to try and avoid them. But there's a large number, and there's a lot in the literature about discussing MR artifacts. So definitely have a look out for that. So you can see, we know about MR and the geometric distortion. So you can see here at the kind of right at the far edges of the imaging field of view, we get a distortion, and it's due to this gradient field strength nonlinearity. And this happens further away from the imaging isocenter. So making sure that your target is within the kind of center of the imaging isocenter is very important. You don't want to be trying to set up a patient and risking this being your target, because you're not going to be able to trust the geometric performance of that image as much. And then just like on CT or CBCT, we also have respiratory motion artifacts. And this can be due to the longer acquisition time. So you can see here, there's a lot of, you can see the motion there. So one thing that we use in our department is a radial sampled MRI, so it's called a vein image. That's our vendor's term for it. And basically it acquires images in a radial fashion, and basically it's kind of more robust to motion. But also it'd be worth looking at implementing motion management in these patients if you haven't already. So with the workflow, we've heard, of course, that the couch doesn't shift. It has a fixed position apart from craniocaudal within the MR bore. So there's two workflows, the adaptive position, which is optimizing on a pre-treatment CT and based after a rigid registration with the daily image. And so that's kind of close to what we would do on in a standard kind of treatment process. Then we have adaptive shape, which we've just heard about, and that uses the new patient anatomy of the day and optimizes on that daily image and those adapted contours, and that's adaptive shape, or ATS, and that's what I'll be just discussing in a little bit more detail. So we've seen this picture before, just showing the two different workflows, the adaptive position and adaptive shape. So adapting to position, it's a virtual couch shift, and we basically move the plan to the patient instead of the patient to the plan as we would on a C-arm LINAC. But it gives us translational corrections only. So this is kind of, mirroring pretty much what we would do without the MR LINAC. The advantage of this is it's relatively simple. It's simple to implement. You could pretty much start using your standard protocols and go ahead. And it's relatively quick because we're just acquiring that image. We're doing our registration as we would normally do. And then we would proceed with treatment. But of course, this doesn't account for shape changes. And this is really why we want MR-guided radiotherapy, or why we want adaptive radiotherapy at all. We want to be able to account for those shape changes. So we have the adaptive shape workflow, where the plan is re-optimized on the daily anatomy, and that's kind of the real-time adaptive radiotherapy, but more on an interfraction basis. And there's advantages potentially with reducing margins or dose escalation, but that needs to be verified in future studies. The disadvantage of this is more people are required in the team, and the treatment times can be much longer. Just a note that the adaptive position workflow, so the workflow that mimics the standard workflow, can be combined with any other adaptive radiotherapy strategies, for example, the library of plans. So because it's not adaptive in itself, we can then combine it with another strategy of a less intensive kind if we prefer. So here's a quick schema of the workflow, but I'll go through it in a bit more detail in a second. And this is just to show the difference in time between an adaptive position approach and an adaptive shape approach, and you can appreciate that it is much longer using the adaptive shape approach. Of course, we have the real-time adaptive radiotherapy as well, but for the shorter time scale changes, such as respiratory motion, but obviously it is a significantly more complex approach. So we've heard just now about the comprehensive motion management upgrade that's available, and with the different respiratory motion management strategies it has, but also exception gating for any treatment site if the target moves out of the allowed position. So some considerations for MR-guided adaptive radiotherapy. We need to think about the clinical indication, the anticipated or desired dose that you want to give the patient, and the proximity to the organs at risk. We need to think about the patient condition. So if the patient is not very fit or cannot lie still or is claustrophobic, then they would not be a great candidate for MR-guided adaptive radiotherapy, because if they're not comfortable, that will increase the likelihood of them needing to reposition during treatment. Yeah, the timescale of changes, as I've mentioned, is important because that will affect what we do. And also there is a treatment field length limit. So it's 22 centimeters, but obviously if we're thinking about our target and the margins that we need to acquire, we actually need to think smaller than that. So it can limit certain indications, and we've seen that in our department. For example, cervix patients that need nodal treatment as well, sometimes that field length can prohibit them being treated on the MR-LINAC. So an example adaptive shape workflow, we will screen the patient to make sure that they are safe to enter the MR room and set them up in the standard kind of positioning that we would do. We would acquire an image and then do a rigid registration from the daily MRI to the initial, to the planning MRI. And then we will, through a deformable registration, do a automatic propagation of contours and then edit them where necessary. In the pancreas, for example, if we had to do all of them, it would be impossible. So we just do a 2 centimeter around the PTV margin, and we will only recontour, edit those structures in that. We will then re-optimize the plan, review the plan, and make sure that it's good. This doesn't look so good if you're not happy with it, but this is when it looks really good. You got all your green ticks, so it's really nice and clear. And we also conduct an independent plan check on a different planning system at the moment, just to verify that the doses are within tolerance. We then do another image, this is called a verification image, and then we do a rigid registration between that and the first MRI that we took that day, just to make sure that nothing has changed since we generated this new plan. If at this point something has changed significantly, we can then go back in the workflow and start again. And then we do our treatment delivery, and we can do motion monitoring with a cine MRI. Currently, we will have to stop it manually if something is happening, if there's a gas pocket, but hopefully with our upgrade that will happen automatically. So with regards to imaging, yes, so when we implemented our MR-Linac, we also opened some imaging studies in our department to help optimize sequences. So there was one that's a multi-institution study as described here, the primer study, and then we also had numerous other studies. And basically we looked at the image quality, we did visual grading analyses based on multiple observers, looking at kind of which was the best sequence or the best parameters to use for different sites. So that's an important thing to go through, not just to go, cool, T2, let's go. But based on your scanner, because each scanner is very different. With regards to treatment, it's important to note that on the Unity, it has its own treatment planning system because it has the static magnetic field modeled within it, as well as the anterior coil. So we use Monaco for that. So just to be aware that in your department, you may then have to have multiple planning systems. And of course, we've heard all about the physics aspects that we need to QA. And then obviously our safety processes. For medical evacuation, we cannot have first responders come into the treatment room with big oxygen cylinders. That would be absolutely terrible for everyone. So we need to have a process where we remove the patient from the room and then have their emergency treatment delivered outside the MR room. So the multidisciplinary team, we have a large number of people, RTTs, RO physicists, and you can see all the kind of breakdown of the tasks here. And just a visualization of our control room and how many people take up all the chairs, and it does get very busy in there. And it's just important to note that when we started with our MR-Linac, we started with standard practice, so our standard margins, our standard dose per fraction, not getting too fancy. So at the Christie, we do adaptive shape for most sites, apart from lung. We haven't treated lung for a little while, mostly because of clinician availability. But yeah, and then you can see the breakdown between RTT-led and the full MDT. So bladder, prostate, and head and neck are relatively RTT-led, so that helps with our resources. This is a quick run through of the RTT training. So we're linked with the MR simulator, the diagnostic MR in our department, and we generated a competency profile for those RTTs or radiographers and the MR-Linac ones. So just to note that kind of thinking about all these things in the big picture and trying to have it as adaptable for your future processes. I'm going to skip that one, and then I'll just show with regards to training RTTs, for example, or changing the MDT tasks. This is just showing a workflow of our initial kind of how we would do a pancreas SBRT patient, and this is how it started. So numerous changing of chairs and changing of staff, but with an image registration competency, we were able to take the registration approval away from the RO, and then with an online organ at risk delineation competency, we were able to be delegated that task as well by the RO. And then in future, we're looking to work towards a competency for plan review and acceptance, and as well deciding whether we can proceed with the treatment. So that's a little bit more involved training program, but just to show that it's all very stepwise and it doesn't kind of all happen overnight. So in future, we want to look at reevaluating margins where possible, but that's not always going to be appropriate, particularly with reducing them. There's also the possibility of assessing response with MRI, because obviously we have those different functional options, and also biologically adaptive radiotherapy, which I think is where we're going to see a lot of the benefit of the MR-Linac. But obviously that needs to be tested in a very stepwise process as well, by identifying your own appropriate imaging biomarkers. So in summary, MR-guided adaptive radiotherapy has definitely benefit for many indications, particularly those that are hard to treat, hard to see, or require biological adaptation, a stepwise approach is required for implementation using the whole MDT. The treatment are currently very resource and time intensive, so we need to optimize our workflows, for example, going RTT-led where possible, and using and designing automated tools where possible, such as auto-segmentation or auto-planning. And I'm finished. Any questions?
For cervical cancer, is your department using an ITV-based approach? Because obviously for MR you probably wouldn't need it, but are they using it, and if so, how much?
ITV, was it? Yeah, so I don't know all the ins and outs of our cervical practice, but yeah, we're using an ITV approach for sure, because we still see the changes, particularly with the bladder filling. The treatments are very long, so there's more chance for changes like rectal changes in bladder filling, or sometimes emptying, unfortunately. But yeah, that is how much, I'm not sure, but yeah, that is what we're doing for now, yeah. Until we have potentially more of the real-time re-optimization available.
And for these sites, are you, when you're doing adapt to shape, is it always a daily adapt to shape, or is it based on a certain traffic light protocol or something like that?
Yeah, I mean, that's not a bad idea in a resource-constrained environment to kind of stratify or triage based on need. That's not a bad idea. Because our machine is viewed as a research machine in the National Health Service in England, so it's only specific patients that we can really get onto the MR-Linac at the moment. So we tend to take a lot of time with them, and we just do adapt to shape daily for everyone, apart from the adaptive positions, which are few.
Thank you.
Did you face any limitation for patient positioning or immobilization devices due to MR coil?
So are there any limitations with which, sorry?
For patient positioning due to MR coil?
Not necessarily. I think there's definitely a kind of size limitation in that the anterior coil is a fixed kind of shape around the bed, so it can come in larger patients, it can come very, very close to them. We prefer for the coil to not sit on the patient's surface, so that can be a challenge, but because we're not treating anything that requires unusual positioning, we're typically treating lying on the back, supine, and typically treating relatively central things, so we haven't had any issues with it, but making sure that they're obviously MR safe and comfortable. We have to really, really focus on comfort because of the length of time.
Regarding vacuum cushion, did you face any challenges?
With which cushion?
Vacuum cushion bag.
With a rectal cushion?
Vacuum cushion bag.
Oh, no. No. We also have like standard like hospital pillows that we can use for some patients as well. If we need to kind of help like make certain parts of their anatomy more comfortable, or we can add padding for places, but yeah.
Okay. Or how will you manage bladder protocols?
Sorry, I'm just going to come forward a little bit.
How will you manage bladder protocols for treating patients?
Yeah, so bladder protocols for rectal patients. I don't think we've done any rectal patients on our MR-Linac yet, not because of any clinical reason. It's more just getting the kind of the whole team on board for that. So I don't think we've done rectal patients, but bladder protocol would be similar to what we would do in the rest of the Linac department. For depending on the site, we would do a certain amount of milliliters and then a certain amount of weight. So it's normally like 200 mils of 30 minutes approximately. But it can be really challenging because that can really change throughout the length of the treatment. And as we mentioned earlier, that you can kind of end up chasing your tail. For our bladder patients, we treat with an empty bladder. We actually found that even though they were emptying right before treatment, the bladder would still fill because obviously they've had fluids during the day. So we would actually get them to refrain from drinking anything for about an hour before treatment, and we found that that was a little bit easier. We didn't have to kind of chase ourselves so much. But yeah, bladder and rectum is, if someone can solve that,
Thank
it'll
you.
be easy.
In LINAC, we have various CBCT protocols which are quite fixed. But here, day to day, when you are using imaging protocols, do you fine tune any parameters to get optimum image quality?
So currently, no, because when we want to image within the workflow, i.e. use that image to adapt the plan or anything, we cannot fine-tune that. We use the Elekta-approved images currently. You can use your own, but it requires a few more steps, and we just haven't gotten to that stage yet. But currently, we use the Elekta-approved ones. And then if we need to acquire any other imaging, the RTTs can initialize some other research imaging while the plan is being re-optimized. So while the physicists are working on that, and we can then take some other images, but we can't at the moment action on them within this, the workflow without some extra steps.
Thank you.
Thank you very much for the very clear presentation, Marit. You mentioned maybe you reduce margins with a question mark. You would think, I mean, if you see it every day and you adapt to shape, then, I mean, if you cannot adapt to shape, so your baseline, then you have a bigger PDV margin. Mm-hmm. So why that question mark?
Just because it was general, and I think there's a lot of focus on shrinking margins, and everyone wants to shrink margins. But depending on what the site is that we're treating, even when we're adapting, because as we say, we might be seeing things that we might not have seen before, using other imaging modalities. So I say it with a question mark because I say it like, take it with a pinch of salt, that it's a possibility, but it needs to be thoroughly investigated, and it needs to be appropriate for the site. And it's not always the end goal to shrink margins necessarily. But yeah, if you want to like do some dose escalation, for example, in the liver, it's very, we're constrained by the normal liver around it. So if we were able to shrink our margins, that would be advantageous to dose escalation. But yeah, I say it with a pinch of salt because I don't want everyone to just go and shrink their margins. That's the fear. It's not always going to be appropriate, but it can be a goal, and it can be realized with proper examination.
Right. Well, it's just in agreement with what we've seen at the ethos. So we have not changed the margins so far with adaptive therapy. We have let them as they are. I mean, people are pushing to reduce, but yeah. Another very brief question. So in these, I mean, I saw all these chairs, I recognize that, and in these RTT-led patients, there is no doctor at all there.
Yeah, there's no doctor with the RTT lead. We will have, again, traffic light. Traffic light is your friend. The Monaco system on the Unity gives us the green, orange, and red, so we can see when something is within tolerance and outside. So after training, the RTT is going through a training for that specific site. So for example, prostate, it's crazy to get an RO down for every prostate that you treat. We train the RTTs, and then we just follow the traffic light, and if something is red, we will then consult. But most of the time, it's not an issue, and we can proceed, and it's far more efficient.
Thank you.
Thank you, Marit. Thank you.
Thank you, ma'am. Next, we have adaptive radiation therapy. What is the evidence for clinical benefit by Dr. Anil? We welcome you, sir.
So, good afternoon. The last pre-lunch session, I won't hold you long for your lunch. So what I'm going to do is to tell you some of the evidence I could collect for adaptive radiation therapy. And since the topic was adaptive, so I had to cover some CT scan based adaptive radiotherapy as well as the MR based. So this definition we all know that we have to incorporate systematic and the random variations, and then we take a feedback and apply on our next session of the treatment, or the same session of the treatment. So we have two systems, we have discussed this enough. So what are the clinical benefits we are looking for? And these can be clubbed into two kinds of classes. One is the dosimetric benefits, and the second would be clinical benefits. Now if you search for the evidence for dosimetric, and there are a number of publications on the dosimetric benefits. So you do a dose accumulation, what you planned on day one and what you ultimately get is called dose accumulation. So you can find whether the dose accumulation, although we don't have the right software, but physical dose accumulation will tell you whether you got the intended dose in the end. And if you compare the adaptive plan with non-adaptive plan, and in one of these studies which I showed, the PTV coverage had improved with adaptive plans compared to the non-adaptive plans. Similarly, dose reduction to the organs at risk, which is, I think, equally important outcome for the patients. And another study you can see here, a dose reduction to the bladder or the rectum to the tune of 37–36% in patients with cervical cancer. So now in this study, another study on the cervix patients, non-adaptive treatment resulted in CTV coverage loss also. Sometimes it may matter between the residual or the controlled disease. And also there was less or no grade 3 toxicity with the adapted plan. So there are multiple studies if you see, and you can have this evidence. In prostate, especially in SBRT, you can reduce the margins, and therefore we hardly see now with these reduced margin grade 3 toxicity, which we all fear, rectal toxicity in prostate cancer. And also the grade 2 bladder and the rectum toxicity also reduces. So now just to talk about some of the clinical applications, because so far we have seen more of physics and technology. Now let's see what we see in the clinics in the CT-based systems. Sorry. So you can see here one of our patients where you can have a patient-specific margin. So you adapt from the population, then you apply that margin from the population-based studies to your patient in first 3 to 5 treatments, and you will find that the patient has, you can find that what kind of PTV margin this particular patient needs. However, this patient may have different kind of contours on different days. You can see here planning CT, the CT image on day 1, CT image on day 2. And if I show you the next slide, you can see in various days, the rectal filling is different. So we have to apply this depending on the rectal filling on that particular day. Another thing which we can do in prostate cancer patient is make a plan library. For example, especially for the patients who have dilated rectum, and this publication, and there was a presentation in the morning also, they have usually higher rectal toxicity and poor local control, the patient who present with dilated rectum. So applying these margins, you can have a library of 3 margins and you make 3 plans. And depending on the rectum filling on that particular day, you apply that plan. So you, in this case, we have shown there are 3 plans, and depending on the rectum filling, you apply that. So this same patient, you can see in the middle figure that at this point of time, the rectal deflated, and there was some dose missing or the dose underdosing at the PTV margin, which you can correct with applying a different plan. So you can improve the coverage of the target, as well as you can look after the dose to the critical structures like rectum. So another method can be adaptive predictive organ localization, which in short we call APOLO method. So for example, we have a carcinoma bladder patient. You ask him to void and then let him drink water, and then you take three separate images at 15 to 20 minutes interval. And so again, you will have 3 kinds of plan with different water filling in the bladder. And that you can apply on the day of treatment. So if you do that, again, there are quite a few of evidence available. You have improvement in the target volume, you have reduction in the dose to the healthy tissues, treatment volume reduction with ART of around 40%, and then reduction in the irradiated volume. So dosimetric, there are considerable studies which show the advantage of ART. This slide also shows the healthy tissue sparing and better target coverage, and also in many prostate and cervix patients, we are also worried about dose of the small ball, and which can also be reduced by applying adaptive radiotherapy. Head and neck, we have all talked of trigger application. If there's a weight loss, so you apply, you replan. And so for all this, somebody also talked about the deformable image registration, which is a very good tool to see ultimately the fusion gets improved, and you can have better prediction of the dose which patient is getting. So this is kind of replanning done on a patient, and you can see the target volume has reduced over a period of time from about 783 cc to 739, and the parotid volume also shrinks, and that is also seen in this patient. And this is also reported that parotid is a very, I would say, unpredictable organ. We promise patients that most likely you won't have xerostomia, but quite a few. Still with the IMRT, IGRT era, 20-25% of patients still develop xerostomia. And all this could be the movement of the parotid medially or shrinkage of the parotid gland. And ART will help in reducing this problem. So the other question which arises is how frequently we have to do imaging. So if you do imaging at 25 fraction, you get nothing. Whatever the constraints are, they're already reached, and 50% of cases, normal tissue constraint was violated. So the frequency of your imaging also is very crucial, whether it should be weekly, twice weekly, daily. This is all a question we always ask in our conferences. Every week, there's a study in every week, and then it helps more, but still there was a weekly replanning could reduce the dose to the parotid, and perhaps weekly is good enough, I don't know, but one of the studies showed it didn't. So therefore, there's a lot of answers to be found. So there's another study with repeat imaging in week 2, and it also reduced the parotid dose, but that is do you do just one imaging at ART therapy at week 2 and get away with all these issues? It is a little debatable. In lung, we had discussed about whether we should shrink. You can see this patient, after 20 fraction, the volume shrinks. So we could reduce the GTV. And since in lung cancer, it's said that most of the time you shrink the volume, and if you shrink, you get the lower dose to the target, lower dose to the lung, and you can have better lung sparing. But the debate about whether that shrinkage, did we shield some of the microscopic disease, is still not very well answered. So people are using PET scan also as an ART device. And in this study, one PET was done 1 week before radiotherapy, and the second PET at 40 gray during the radiotherapy, and they saw volume reduction, and which also got a better normal lung doses. So you can see here in this study, there was a benefit in all OARs. You can see the benefit in total lung dose, you can see the benefit in the heart dose, esophagus, they're all statistically significant. So probably we save a lot of normal tissues by doing adaptive radiotherapy according to this study. So what we can get, if we have good adaptive radiotherapy, maybe we can reduce our PTV and would allow dose escalation. But there are limitations to both online and offline adaptive radiotherapy. This is online, number of, after how much time, so how many initial observations you will look for, multiple plan effort, who decides the plan, whether it's a radiation oncologist or it would be RTT. We need fast contouring tools because we have to be ready for the next fraction, and fast optimization and staff training. Similarly, offline art also has its problems. When to trigger the replan, nobody knows. And should it be daily, is time consuming and cumbersome. Contouring uncertainties in the repeat imaging. I have done a contouring and some other doctor does contouring. The next time there may be a disparity, accuracy of average dosimetric endpoints and so on. So all these, both the methods have some issues. So we have some experience with the MR-Linac, and the technology we have all covered. It has got a MR, 1.5 Tesla MR and a Linac, and this is our Linac at our center. So why we should do MR-guided, MR-GRT as we call, and we all know that it shows tumor margins clearly, better soft tissue contrast, and we can see tumor very clearly, we can see OAR very clearly, and therefore, we can reduce margins. You can reduce margin in CBCT guided radiation also, but you cannot do it because the margins are not very clear. Maybe prostate and rectum interface is not very clear on a CBCT. That is much clearer on an MRI. We can adapt real time, and this has been covered, that we can do a real time imaging. We take the MRI just at the start, and then we transfer the plan and do a recontouring. And I can tell you, out of 40 minutes, we consume 20 minutes in recontouring for ATS. So radiation oncologist has to be a little fast in MR to recontour. And the other thing which we have in MR-Linac is dose optimization. So once we are done with the anatomical shift or whatever changes we have made to the target organ, the plan is optimized. So now we see real-time doses going to the tumor, various parts of the tumor, and also to the critical structures. We can monitor motion, intrafraction, so it provides very good online intrafraction motion management, and we can also assess response, but that is a thing which needs more studies. So this is a typical CBCT-based workflow, and this is what we do in MR-Linac. You have a pre-treatment CT scan, we're planning CT scan, and then you contour and you plan it, and then you have an online MRI when you take it to the Linac. While we are doing a pre-treatment CT scan, we often fuse it with MRI and a PET scan. That is all inclusive in that. And then we do a first MRI as soon as the patient is on the couch. Then you do a contour adaptation. Whatever the contours we had drawn on CT scan, planning CT scan, they are adapted on the MRI. And sometimes this is initially when we see, sometimes you need a lot of reorientation to the MR. And then you do a bulk density correction because it is an MR-based system and you have to calculate the dose, so you have to have electron density from the CT scan. Then after completing this, then you have an online replanning, which is quite fast. I would say it takes 3 to 5 minutes, and which is one of the fastest tools in this system. Then we verified this MR contours with the dose distribution, we verify, and then the radiation is delivered, and then I can show you the online MR, Cine MRI, which is available, and with that we can monitor the motion. So So MRI, what are the advantages that they have? It has a in-room imaging with MRI. We have various sequences. Dr. Daly has also said. So you choose the sequence while planning. If during planning we find T2 gives the best image quality or the best tumor delineation, we will use the same during the treatment. Then we have both rigid and deformable image registration. And depending on the organ rectum, sometimes you see better with the rigid registration, sometimes you see with the deformable registration. So these are the tools available to you to utilize and improve the quality of fusion and registration. Then there is an accelerated dose optimization, as I said, and then patient-specific QA. So I will give just one or two examples of what we have done in the last 4 or 5 months. Is in pancreatic tumor, where this is supposed to be one of the imaging model or the radiation modality of choice, because pancreas is surrounded by many critical structures like stomach, duodenum, small intestine, and it's one of the most difficult tumor to treat. And you can see that if you can make out, I don't know, there's a blue area where it was empty, and during the second fraction, that blue area in the other slide with the white arrow, a small ball segment has moved in. So what we planned, that there is not much of dose or the dose limitation to the small intestine, but on the day of treatment, that very area has been occupied by small ball. So this is where the yellow area, the loop has moved in, and whatever, so on that day, small gut would get more dose if we don't have adaptive planning of this patient. So some of the studies on MR-guided radiotherapy for pancreatic tumor, and this is the study which was published, I think, last year. And so what this study has shown is the improvement in the PTV coverage as well as the improved doses to the OARs. And you can see here that as you escalate the dose to the pancreatic tumor, we need a dose escalation to have better tumor control. So as you escalate the dose, there are more and more ATS, more and more adapt to shape, adapt to shape. We cannot do with adapt to position in pancreas. So in this study, they gave 50 grain, 5 daily adapted fractions, and the median follow-up was 10 months, and this is one of the earliest studies which showed an improvement in survival. Very difficult to do a study on a new technology which can show an improvement in survival. But in pancreatic tumor, there is now accumulating evidence that MR-Linac can improve the survival of patients with pancreatic cancer, and the 1-year local control, 86%. So this is a new adjuvant where with after chemotherapy, you give stereotactic ablative radiotherapy with the MR-Linac and then subject patient to surgery. And in this also, you can see a 1-year local control around 91%. And these are some of the other studies which are showing local control in the range of 80 to 90%. This is another good trial where this radiation and chemotherapy was used in resectable and borderline pancreatic cancer. And it showed that patients who got radiation along with neoadjuvant chemotherapy, they had better R0 resection, they had better nodal negativity, and other high-risk factors like PNI was better in patients who got who got chemoradiotherapy rather than chemotherapy alone. So here you can see this pre-op PANC trial, which shows the pre-operative chemoradiotherapy does better than an upfront surgery. So even in directly operable or borderline, we should convince surgeons to have this pre-operative chemoradiotherapy rather than upfront surgery. So just giving an example of one of our patients, CA pancreas, this is treated. I think I have a short time, so I have to rush through this slide. So you can see the position of the duodenum changing every day. So what we had planned, you can see in the bottom box, the dose. So it is a sub-volume dose which we have to do in pancreas very often, because part of the pancreas indenting or overlapping or infiltration or suspected infiltration, we cannot give the same dose as the rest of the tumor. So sub-volumes are made, and you can see the dose delivered on day 1. Day 2 is little more. Duodenum is coming near the tumor, so we have to again do. So GTV dose is separate, and the ITV and PTV doses are separate depending upon the movement of the duodenum or proximity of the duodenum to the tumor on that day. This is on the 3rd day, it's the 4th day, and the 5th day. And this is the accumulated dose. You can calculate that whatever I had planned, CT planned dose, how much dose we could deliver, and you can see that most of the planned doses which we had thought of, we could deliver, and controlling which are less reliable organs around the pancreas under control and under the constraints which we had planned initially. So in prostate, I will just mention that we all know that this is the CT picture, this is the MR, so much difference in the quality of image, that is how we can see. And we all miss in the CT, the apex, there's some areas which are missed, and the posterior portions are frequently missed because of the proximity to the rectum, and the junctional zone is not very clear in a CT scan. So MR it helps in improving our contouring and also identifying the dominant lesion in the prostate. So this is one of our patients where we took his MR every 10 minutes, and you can see how it changes. So we have to be careful at what point of time we have to take patient in the MR linac after having water with the bladder protocol. This is a study, this is a case presentation kind of publication which showed that with MR adapted plan, they could reduce the dose to the rectum in this patient. This is one of our patient, image quality and the dose distribution you can see around the tumor. So this is like when the patient is under treatment, we can see very clearly the motion management. You can see if any, especially in SBRT, if even a tiny portion moving out of this green circle is a matter of concern, and we can interrupt the treatment. So this is another example of a small suprarenal tumor. This I got from another publication. And you can see here the small suprarenal tumor with a patient who has one kidney. Other kidney was resected because he had renal cell carcinoma on the other side. You can see this small tiny tumor with a lot of reliable image monitoring one could treat, and this patient achieved a complete response. So prostate cancer, we have some evidence, randomized control trial, Mirage trial, and it showed that what we can do with MR linac, and we had discussion in some time back, can we reduce the margin? Yes, in MR, we have more reliance. We can reduce the margin because of superior image quality and superior junctional zone between maybe the prostate and the rectum compared to the CT scan and cone beam CT. Therefore, we can reduce the margin MR linac not very reliably in a CT scan. So this study had CT margin 4 millimeter and MR margin of 2 millimeter. And so what they saw was that there was a reduction in grade 2 toxicity, statistically significant GU toxicity as well as GI toxicity. And the IPSS score was also better in patients with MR guided. So this is the same thing shown in here. So there is some evidence to treat gliomas, and Sai was showing some of the glioma patients. So here also, they have reduced the margin. The CTV was gross tumor volume and 5 millimeter margin, and the PTV was 3 millimeter, and they have shown a mean reduction in CTV margin of 40% in the adapted plan compared to non. And we all know elderly GBMs, they have a problem of normal brain side effects, neurocognition and drowsiness. So that is how it can help. So this is a comparison, and So between the MR, the CBCT, and the PET-guided art is also available. We have not discussed in this, but PET-guided is still more complex, but it is available. So these are the pros and cons. CBCT is still the working horse. It's fast. It is, we all of us know, but we all know its limitations also. MRA can do so many things which we have talked. So this is the comparison you can see. So in conclusion, adaptive radiotherapy improves the accuracy of target coverage. That was our first endpoint, the dosimetric benefit, and we can improve target coverage. And when we improve target coverage, it is like doing a dose escalation, because if you prescribe a dose and that is not covered properly, it is a dose reduction actually. So we can have a dose escalation by way of improved target coverage. It allows tumor dose escalation in, for example, dominant nodule in prostate and some areas in pancreatic tumor and other things. And it can reduce normal toxicity by reducing dose to the OARs. We have seen rectum, bladder, and the gut and duodenum. And it has shown, early studies are showing survival advantage in pancreatic tumors. So this methodology is well poised, and we have all to see how it goes in the future. Thank you very much.
Thank you, Dr. Anand. Any questions for Dr. Anand?
Yeah, Dr. Anand, very, very nice presentation. Obviously, you're passionate about MR-Linac. Yeah, I think your last slide showed, I mean, we can improve target coverage. I think for, I don't know, but maybe 99% of the patients treated without MR-Linac, the target coverage is okay. So how can you improve?
Yeah, so I showed so many studies. Our intended plan so many times will not get what we have planned and on the execution side. And some 40% of patients had improper CTV coverage or some of the areas missing in the PTV. So target coverage improvement is shown by many, many studies. And so are the doses to the OARs. So target, because we had a discussion whether the target covered D95, V95, or it should be D95, 99%, or D95, 98%. So somehow to improve that, we have to have something more.
Yeah, but I mean, but yes, there are studies showing that maybe the target coverage is better, but that's not for all patients, right? That's for some patients.
Yeah.
But another question is, I mean, this is a more global question. So how would you qualify an MR-Linac at this moment? I mean, is this a very, and I mean, I'm passionate also about it, but is it a research machine, or is it, so should you have it if you want to really explore the opportunities,
yeah,
or is there enough evidence that you would recommend the people here go for it?
Yeah, so it's a very difficult question. So I think I remember our IMRT days. So when we started IMRT in 2002, the West started about, I think, 5 years before. Same question was being asked whether IMRT was superior to 3D CRT. And now we know IMRT is superior. Again, IMRT has not shown survival advantage in many tumors, except perhaps nasopharynx. But what IMRT has done has reduced its toxicity. And we have seen that in our clinics. Earlier, we used to see patients with xerostomia, a lot of fibrosis and dysphagia. Chronic dysphagia was a very frequent problem. And now we see very little. So I feel very, very good seeing patients treated with IMRT. They may not be surviving, the survival has not improved. But those who have survived, they have a better quality of life. I think same question is for the MRI. I have encountered some of the rectal toxicity, maybe 2 or 3 in my life, but I remember all 3 patients. That is terrible. Rectal bleeding, And so everybody says rectum is prostate is a curable tumor with very little side effect, but the one who gets it is a problem. So I think somehow, despite all those CBCT studies, still we get anything between 5 to 15% grade 2 to 3 rectal toxicity across the world. If you explore the literature, it is not less than, grade 3 toxicity is not less than 3%, it is higher.
But I believe that, I mean, there's rather a difference between the comparison of 3D CRT and IMRT and cone beam CT based on MR-Linac, that's money. So going from 3D CRT to IMRT didn't have a big price. But going to MR-Linac, I mean, it's not only the purchase, but you have 45-minute treatments. So then, I can imagine in that period that we went all to IMRT because, I mean, yeah, a blind could almost see that was better and it didn't cost much more. So, yeah, I'm not sure that was a good idea, but it turned out to be a good idea. But for MR-Linac, I mean, you're also talking about cost effectiveness. And so, is it like for you that clear that we should, I mean, we should go for it?
Yeah. So I think we have to have patient selection. I take your point. We cannot just offer MR-Linac to everybody. So we have to have a patient selection. Recently we saw a patient with prostate with ulcerative colitis. And the surgeon had ruled out that patient. So this patient we will treat on MR-Linac for a more predictable dose distribution. I think we are more predictable in MR-Linac compared to CBCT. That is one thing. So in pancreas, I will treat every patient on MR-Linac because we have burnt our fingers with angiodysplasia in the stomach and duodenum, 40%. If you see pancreatic study, angiodysplasia rate is 40%, and therefore surgeons are very scared of sending us for pre-op radiation. And if you see these studies, they are saying pre-operative chemoradiotherapy improves survival. So if we are unable to deliver a safe radiation to pancreas, surgeon will never agree with us.
Okay, thank you.
Yeah, this is related to the workflow, and this is something that Dr. Anand has spoken about and Mary as well. Given that there are quite a lot of variations in delineation between radiation oncologists, in terms of adaptive replanning at the console, how do we ensure that the clinicians don't really change a lot of the initial, if you like, volume, or in a way that is probably contrary to what the original clinician would have intended? I mean, is it possible, and how do you ensure that in your departments?
So similar question. I mean, is it the same person who comes and contours in a doctor-led?
Yeah, it's a very good question. For us, it is the same clinician, so that removes the inter clinician variability, but the intra clinician, what they would have done, you know, on a kind of side-by-side basis or case-by-case basis is still there. But yeah, it's their case, it's their patient, and yeah, that's something that we can look at in like offline studies. But yeah, we have the same clinicians for mostly just due to number of clinicians available to do it.
I think I can just add, so there are some salient features about each patient, and that should be clearly mentioned in our file which we keep on the MR-Linac. For example, this patient of ulcerative colitis means the right side colon had ulcerative colitis, and some of this portion was quite close to our target. So these kinds of some of the peculiarities of the patient, the next physician may not notice or he may not remember. And those things have to be put in. It's very important that in some block letters, some color, so that we don't miss those. It's very important, yes.
I would like to ask Dr. Hope, I'll pass on Ben's question to you. Do you think MR-Linac is a research machine, or is it something that's open for?
Yeah, no, that's a great question. I think by definition, until we establish clear situations where it is the de facto standard, I think it is definitely a research machine. However, that being said, I have found situations where I feel it is distinctly superior. And so in those situations, I do feel like it is a... Yeah, so the situations that I've found largely have to do with proximity to critical structures where cone beam-based image guidance would be inferior. And so the best situations that I can think of recently, I've had a couple situations where I've had tumors that were very central, adjacent to the esophagus and directly behind or near the heart. And so in that situation, especially with a cone beam, it's almost impossible to guide accurately and understand what the proximity to the esophageal critical structure is, but also just to kind of monitor the position of the tumor from an image guidance standpoint. And so in those situations when we've been doing oligometastatic or central SBRT type treatments, I've been able to avoid the esophagus successfully while maintaining good dosimetric coverage, at least, of the target, and monitor that dynamically in real time while we're actually delivering dose. And so I think there are definitely situations where the improved imaging lends itself very clearly to a very specific situation. I can't say that it's a high throughput machine. That's never going to be the case, at least with the current workflows. But I think in certain circumstances for hypofractionated treatments that are in a very specific kind of target and OAR orientation, it definitely has advantages. And I think it really does, in those situations, quite shine.
Have you done, daily, adapt shape or something for those patients? And not just for esophagus, but also for example, proximal bronchial tree or something like that?
Yeah, no, I think of the two targets, two OARs, we've been preferentially sparing the esophagus over the bronchus in those circumstances. So we've had, I've treated now 5 or 6 patients in the last year who have had tumors that were effectively jammed between the esophagus and the bronchial tree or the posterior aspect of the heart. And in those situations, we've been tending to favor the esophageal OAR from a dosimetric standpoint, just because we think that we have a 32 gray threshold for our 5-fraction regimens that we feel is quite a bit lower than the 5-fraction regimens for the 5-fraction threshold for the proximal bronchial tree. That being said, maybe we're wrong. Maybe we should be pushing dose somewhere else, except for away from the esophagus. But I think preliminarily we've done quite well with these patients. They've had minimal esophageal toxicity, and they've all been relatively they've done well with this. But this is, again, part of that early experience clinically. It's kind of a research situation, but it would be very difficult to accomplish this on a cone beam-based system.
Can I just answer your question you raised earlier, how many times you do ATS or ATP? So in the intact prostate, moderate size, not very large, so many times we find that we are doing ATS, but so many days you find the anatomy is kind of same as yesterday. So we tend to combine sometime the ATS and if anatomy permits ATP. But in post-operative prostate, I found variability much higher. The gut is all around, and so then it is ATS all the time.
I just wanted to add that in our department, we're going to focus the MR-Linac on the cases that are hard to see and hard to treat and require biological adaptation in the future once that's validated. And we currently have C-arm Linacs, CBCT Linacs, but once they get upgraded eventually to a ring-based system, we will then be able to complement and have a kind of complementary adaptive service on CBCT base, which is going to be more of a workhorse for the department. In the short to medium term, an MR-Linac is just not going to have a high throughput the way that it works. So a CBCT based option will definitely be better for the cases where it's more straightforward. So it may not necessarily be binary in the longer term for a department.
Thank you. I think we'll take that as the last question before
we
lunch.
have MR simulator at our center. and we start acquiring the images on flat table and with the immobilization devices. But what we observe that the CNS consultant are not that much comfortable to use the MR images with the immobilization because of the inferior image quality as compared to the without immobilization. So what is your experience?
Yeah, so one comfort in MR Linac is that except for head and neck and brain, we don't use any immobilization device. No cast, no ORFID cast. So what you have 3 indexing positions, and those 3 index positions of the patient are indexed to the couch, and that's it. And that have to be matched, and otherwise they are not caged into a cast where they will not permit the coil. And coil is very comfortable. If you see the design of the coil is quite comfortable. Only thing is that you have to bring it, one portion you have to bring it down for improved image quality, but otherwise it's very comfortable. And 40 minutes patient lies down on prostate, they never complain that they are tired because they are not caged in a ORFID cast.
So how comfortable you are while delineating the target in the CNS region with immobilization?
No, so in head we have head and neck. Otherwise, the rest of the body no. So we are quite confident because we are seeing post-verification image also. So ultimately, we have to rely more on anatomy rather than on surface or tattoos or bone. We are just seeing the tumor directly. So you get more confidence that you are targeting very accurately.
I think, you know, your question is about the quality of the MR and how it gets affected by visualization. But you know, I think that the major benefit, I think what Dr. Anand is trying to say, is in the verification, not in the initial contouring. It is the benefit he gets out of the verification that really helps him, you know, choose the MR Linac in certain situations.
But they are using daily same images for the contouring for the adaptive purpose and all.
Yeah.
So that's why I'm asking.
Yeah. So image quality, many times we do planning on the MR Linac itself. So we take a CT image and MR image on the MR Linac. Quality is same as diagnostic quality. We have compared and we have asked our radiologists to come over there. They're same quality image. Dr. Daly will tell what is the image quality. Is there any image quality difference between 1.5 of Tesla MRI on the MR Linac and diagnostic MR? We found almost similar.
Very slight differences, but nothing
Yeah,
significant.
not very different. Yeah.
No, maybe here the difference will cause due to the MR coils because you may have air coils.
Yeah.
Whereas we
Yes,
don't have.
the coil is very comfortable here. Yeah.
Thank you. We've kept you from lunch for a very long time, so we'll break for lunch now. We'll try to be back in about 40 minutes. Thank you.